Hello, hello, check. Hello, sound check. Check 1, 2, 3, 4, 5, 6. Hello, check, check. Hello, hello, check. Hello, check.
morning, everybody, and thank you, everybody, for coming back to the physical conferences and gatherings. And happy Teachers' Day to all. So I will start the proceeding. So I will invite our past Secretary of West Bengal Orthopedic Association, Professor Kiran Mukherjee, to start the proceeding.
Good morning, everybody. On behalf of West Bengal Orthopedic Association, I heartily welcome Dr. B. Shiva Shankar, our president of our beloved organization, Indian Orthopedic Association. And we are very happy to have a senior past president here of West Bengal Orthopedic Association, Professor Shubir Mukherjee. And we are grateful to the management of Joint and Bone Care Hospital for allowing us to have this physical program, and live workshop will be operated by Dr. Shiva Shankar and another case by Dr. Sunit Hazra and Dr. Soumitra Mishra. Dr. Soumitra Mishra and Dr. Sunit Hazra. And now we welcome Dr. Shiva Shankar Rao with a flower bouquet. I request Ms. Honor to hand over a flower bouquet to Dr. Shiva Shankar. So we are very happy to have this physical program after a long time, and we start this physical program with our beloved President of IOA. So this is a great thing to us. That for the first physical program we are having our president sir with us. Now I request Dr. Joydeep Banerjee on behalf of Joint and Bone Care Hospital and also a senior member of West Bengal Orthopedic Association.
Good morning, everybody. Welcome to Joint and Bone Care Hospital. This is a very new institute. I'll just tell you about a couple of lines about this hospital. This is very new. We have started in 2018, but however, with the COVID situation over the last 1 year, we were almost sort of running at a very low gear. However, my whole idea was to create or build an institute which would be single speciality. We deal with only orthopedics and orthopedics allied subjects. I'm very fortunate that I have got huge support from my fellow colleagues and juniors who are coming here every day, every day with the week, and we have succeeded in doing lots of surgeries, cases, and all types of variety. I really get surprised in days when I look at the OT list that you have varieties of joint replacements, arthroscopic surgeries, spine surgeries, and the whole sort of ethos of creating this institute was to have everybody under one roof and to serve orthopedic ailments, to sort of cure all orthopedic ailments under one roof. We have managed or succeeded in doing that, but obviously with the help of everybody. Today we have got Dr. Shiva Shankar, who is the president of IOA. Itna bada delegate aaya nahi kabhi Joint and Bone Care Hospital mein. But this is the first day, so I feel really proud, really happy in welcoming you to this institute. Thank you very much.
So we'll start the academic proceeding. So I'll invite our past president, Dr. Shubir Mukherjee sir. No, sir, to preside, to do the chairperson, and he will invite. Sir, please. And Dr. Joydeep Banerjee Choudhury too, as a chairperson also.
Good morning, everybody. I request our President IOA, Rotary Dr. Shiva Shankar, to have the chair.
morning, everybody. Respected chairpersons, past president Dr. Subir Mukherjee, and the main person of this Joint and Bone Care Hospital, Dr. JBCH Mukherjee, my friend Dr. Rajiv Raman, and other people here today. The topic I'll be giving will be my journey with intertrochanteric fractures for the last 35 years, and what are the predictions of a good outcome in a PFN. I did my MBBS from Karnataka Medical College, Hubli. Then through All India entrance, I did my post-graduation from Sholapur Government Medical College. The Department of Orthopedic had only 2 private practitioners as honorary professors. They were just getting 250 rupees for petrol allowance, nothing more than that. But the department had very great teachers, and I am here only because of these 2 great teachers. I bow to them on this Teachers' Day for carving me as well as many students like me. The unwritten rule in the department, in the first 6 months, a resident will do radius ulnar nailing, femur nailing. Then second term, he will do the duet nailing for the hip intertrochanteric fracture. Second year, he will do the AMP Richards. Third year, if he is good enough, then joint replacement and the spine will be given as a resident. So student will get lot of in a government setup working there. Only thing is, we are only answerable. If I do anything, I am answerable to my teacher why I did this. That's all. They used to question us, and we had to think before doing any decision, taking the decision and treating them. So you may not have seen these implants. On the left, you can see the Smith-Peterson nail plate, and on the right, you can see the Jewett plate. X-rays also, you may not be aware. Earlier, we were taking X-ray with small machines like portable machines, and that used to be developed, then dipped in water, again fixed and dried. It used to take out 15 to 20 minutes to get good quality X-ray. And if the quality of the developer and fixer is low, then it used to take even half an hour for that. So when we are doing operations in the OT, you used to insert guide wires into the hip joint, ask the technician to come and take an X-ray, and he used to go back to the X-ray department, develop it and bring it. For one X-ray, it used to take 30 minutes. Even if the boss is operating, everything will be on fast mode. That time it will be 20 minutes, that's all. So that's what we have learned. And there were some of the days there used to be no intraoperative control also, especially when the electricity goes off, and such things were very common. That time we used to extend the incision. Earlier the incision used to be like this, but we used to extend it above like a Watson-Jones incision, and feel the neck above and below, and pass the guide wire and do the surgery without X-ray control also. I have done myself. This is SP nail plate, where you can see the tripline nail and a plate which is little different, and the plate is very, very flimsy and thin. It used to bend a lot, especially in subtrochanteric fractures. So McLaughlin plate on the right side, you can see, which was little thicker. The advantage of McLaughlin plate was there were serrations, as you can see, and you could lock them at any angle, at 120 degree also, at 140 degree also. Whatever the way you want to lock it, you can just lock it. But unfortunately, this many a time this used to slip away. Thanks to lockdown, I had the opportunity to see so many of my slides and revisit them. These are some of the slides. Some of the case I have done myself only. That's the reason why I taken the slide and I put it. A subtrochanteric fracture treated with a SP nail plate. Unfortunately, the plate, as I said, was a little flimsy. That's why it has bent already. And also you can see the loosening of the nut screw which fixes the plate with the SP nail. Another case, again you can see the bending. So that's why we started using a single implant. The nail and the plate welded, and the plate is also quite strong enough. That is, the Jewett nail plate became more popular, and it was very good implant, especially for a stable intertrochanteric fracture. For unstable fracture, you can see penetration was very, very common, and in a osteoporotic bone, cutting through like this was also very, very common at that time. So the sliding hip screw or the Richards screw became very, very popular, where the screw slides within the barrel plate, and that is what we are all aware of in the last few years. And again, for a stable fracture it's good, for unstable fracture it is sometimes it is questionable. This is my own CA's mother, chartered accountant CA, and she had this stable fracture. You can see it's a quite stable fracture, but see the amount of collapse which has happened in spite of this being a stable fracture, because this uncontrolled collapse is something which is a problem with the this instrument, so this sliding device. So much of screw which was outside on table, this is after the end of the surgery where I have already collapsed the fracture, then it has further collapsed and totally it has gone out. So that is the, though for a stable fracture it's a good implant, for an unstable fracture we all have seen cut through, penetration, everything. We all know the Baumgartner principle of tip apex distance. To have dynamization along the shaft, not just along the IT fracture, even for subtrochanteric fracture, this plate was invented where you can have a plate within the plate sliding, and that also was very useful. But the problem with the basically DHS is uncontrolled medialization till the fracture attains its stable fixation. So if the fracture is in a valgus reduction, many a time it attains the stable reduction quite early. If there is even minimal varus, then there will be uncontrolled medialization. So these are two examples of a good valgus where the fracture has attained a stable reduction quite early without undue collapse. So to prevent medialization, the trochanteric support plate or a trochanteric buttress plate came in the market. Again, we all know that in an osteoporotic fracture like this, if during the surgery almost 30 to 40% of the cases where it is a stable lateral wall, because that lateral wall is very thin, breaks during the surgery, especially while inserting the triple reamer, and it becomes unstable fracture, and we all have seen the result of unstable fracture is undue collapse happening along the shaft. So this is a good fracture which was treated very well on table, but just at about a week's time you can see there is undue medialization which has happened because of the lateral wall fracture which has happened inadvertently during the surgery. So this is bound to fail. The picture on the right is bound to fail. So can we predict this medialization and failure? This article came to my mind where they say that even without any medialization about 10% of the fracture fixation fails. But if there is 30 to 60% medialization, about 60% of the fracture fails. If there is more than 90% medialization, 100% of this fixation fails. This is about 25% medialization. You can see the lateral wall of the greater trochanter and lateral wall of the shaft here. About 25% medialization have happened, 1 in 4 will fail. This is 50% medialization, 1 in 2 will fail. This is 100% medialization. Means if you see an X-ray, post-operative X-ray like this, you are 100% on a bond paper you can write down saying that it is going to fail. It is not going to unite. It has either cut through or whatever, but it is not going to unite. So by preventing this medialization, we can get better results. To prevent this medialization with a DHS, we have a trochanteric buttress plate. Similarly, to prevent medialization, if you put an intramedullary rod, that also works in the same principle. The nail prevents further medialization. That is the reason why nail works little better. So this is an osteoporotic fracture. Prophylactically, trochanteric buttress plate has been used. This was a case I was operating, and you can see that I have inadvertently broken the lateral wall. Immediately on table I realized it and used a trochanteric buttress plate, and it went on well. Unfortunately, the trochanteric buttress plate available in the market may not sit properly in all our Indian bones, especially elderly females. So I started using my own T plates and L plates as trochanteric buttress plate. I apply the DHS first, and I remove 1 or 2 screws from the plate here, and then I apply the plate through the, over the DHS plate through the same hole. So that's what I normally do. You can see 2 screws have been put through the plate. This is going to both the plates. So that's how I use it. This is very young person, you can see, very less than 4 feet tall and narrow middle canal. So PFN was out of question. I was doing a pediatric DHS, and again, you can see the excessive valgus. That is because of the breaking of the lateral wall. So immediately on table, I decided to put a trochanteric buttress plate, and this patient has done extremely well without any problem. I have removed the implant also. If I had not put the plate, 100% it would have gone into failure because uncontrolled medialization. So to prevent medialization, I am applying the plate which prevents the barrel to go much more medially. So this plate, I call it as Aam Aadmi TSP, because any plate, any DHS you are using, L plate, even a recon plate, small recon plate also you can put and you can get away while doing the surgery. You all know I have been conducting nails workshops at so many places. This is in Bilaspur, this was in Pune, this is in Chandigarh. You can see the past IO president Dr. Nagi felicitating me. This is in Mumbai, Thane. So many places I conducted the workshops. While I was conducting one of the workshops at Visakhapatnam, one Dr. Ane Satish, he said, sir, bread and butter of orthopedic surgeon is, DHS is the bread and butter of orthopedic surgeons. You should do something keyhole surgery for DHS also. I took that as a challenge, that his words as a challenge, and started thinking on that, and that's the end result of a DHS with a very small incision. Designed a sleeve, thanks to Tushar Pandya, who is here from Yogeshwar Implant. Whatever I was asking, he used to make the instrument and giving. Instead of the triple reamer, I got a double reamer done specially. The third part of the reaming is not there in that. And with this innovative keyhole DHS, with a small incision like this, less than 24 millimeter, less than 2 centimeters, I was able to do the surgery. You can see the video on the YouTube. Those who attended the Ganga operative trauma course, I have done both the times the keyhole surgery as a demonstration. The whole video is available on the YouTube again. Sometimes I use just a band-aid to do the dressing. Such a small incision, it's possible to do the DHS. It's search for Dr. Shiva Shankar or keyhole DHS, you will get it on the YouTube. Then, to increase the stability, inherent stability of the fracture, you can get the beak inside the distal medullary canal, which is called as Diamond-Houston type of reduction, or you can break the part of the trochanter and make it so that it will come in a better way, and you can put the plate through the fracture site, and you see that your reduction is better. So DHS alone is not going to be of help. Basically what I wanted to tell is uncontrolled sliding will cause trouble. DHS alone is not the gold standard. It has to be along with a trochanteric buttress plate or with a made-of plate. DHS alone is like a 24 karat gold. Anybody is wearing a 24 karat gold instrument or anything? No. The goldsmith cannot work on that. He has to mix copper. So this TSP and made-of plates are copper-like. Then only it becomes useful for the person to use it as a good metal to make ornament. So this is about the DHS. Now coming to, after my MS, I went to England for joint replacement fellowship. Then I went to AO group like Catherine Hospital and the Holes and did my fellowships there. And I had the opportunity when I was working with Dr. Holes. He used to send me, wherever there is some workshop used to happen, he used to send me. I attended few workshops in Freiburg and other places where I learnt about the gamma nail. And the third way of decreasing the bending moment or increasing the stability of the fixation is, instead of a surface implant, use an intramedullary implant. So when I came back to India, then we had these Haldar's nails available at that time, the gamma nail. So I started using this Haldar's nail. So thanks to Dr. Haldar, you invented it from your own place. Kolkata is originally, but now he's settled in UK, Halifax. And he has come to so many activity of mine. I called him for Nails Con. He came to meet the master at Aurangabad, then nails, operative nailing course, then IOA Con he came. Whenever I have called him, he has obliged by coming on his own from England to teach the technique. So this is Dr. Subhash Haldar's Halifax nail, and Gross at the same time saw this design and he came out with a similar nail, but Dr. Haldar went to the court. I threatened the company that I am going to the court, and the How Medica people said, yes, we have copied your nail, and they as a middle path regime said, we'll not call it as Haldar's Halifax nail, we'll rename it as Gamma nail. It looks like a gamma. So that's how the Gamma nail came. Gamma nail was designed by Dr. Haldar, or it is from the Haldar's Halifax nail, the Gamma nail has come in market. There is a beautiful discussion. I conducted a one person, one talk series with Dr. Haldar. 2-3 talks of him are available on the YouTube. So you search for Dr. Haldar and there is beautiful talk of almost 1.5 hours about intertrochanteric fracture, tibia nailing, humerus nailing, so many. I conducted 3 workshops during the webinar with him. So when the Gamma nail were available in the market in India, I started using them. That was sometime in 96 I started using them. For stable fractures they did very well, but this part was too thick and I had little problem using in a non-osteoporotic bone. Fixing the Gamma nail in an osteoporotic bone was not at all a difficult, but a thinner canal I faced lot of trouble, and I gradually stopped using it till the time the PFN came into the market. PFN is not designed by you, me or somebody. It's all the people who were using Gamma nail came together and they said these are the problems with the single screw system. So they designed. Everybody's input were incorporated and PFN was designed. So this is a smaller diameter in the subtrochanteric area, 2 screws instead of 1, 2 distal locking away from the tip. In 1999, I had the opportunity as an Indo-German Orthopedic Foundation fellow to visit Germany, Düsseldorf. That time, I had the opportunity to assist PFN while I was working as a fellow there. When I came back to India, I took a lot of pictures of them and I handed over the pictures to Mr. Tushar Pandya. And this is the first Atmanirbhar Indian implant was available to me sometime in November 1999. I did the first surgery in 1999, the first Indian implant PFN, the first surgery was done by me. Since then, the design has never changed. The length was little reduced because Dr. Gadegone from Chandrapur had lot of trouble in inserting a 25 centimeter nail in a curved femur. In the central India, they have got sickle cell and the bone is little more bent. You can see even a 18 centimeter nail is difficult to negotiate into the canal. So I met Dr. Gadegone in one of the conferences and he asked me, can we reduce the length of the nail? I discussed with Tushar Pandya and that's how the TFN came in the market. Unfortunately, none of us patented the word TFN. So somebody has patented the name in 2017. So we have come out of TFN in 2003. This was designed in 2003, but patent was done by some other company in 2017. Anyway, I have been using since 99 PFN. I don't say that whatever I am sharing, I have done suddenly everything good. No, I have done a lot of mistakes, but whenever some problem has happened, I have tried to analyze them. Why this has happened? Why this has happened? Why this failed? Why I didn't get the reduction? That is the reason why I could analyze over so many years and I never left the PFN. Many people did the PFN in the initial period. They had problem, they left it and went back to DHS. But I never left the PFN. In spite of I had my own keyhole DHS technique, I persisted with that PFN and I am sharing all the tips and tricks with you. There are so many problems with PFN. People do various ways a PFN, which is not as per what we require. These are some of the examples of the pictures our own colleagues have done at different places, the PFN. So the next part of my talk is what are the predictors of the outcome or when I will be happy after doing a PFN surgery. These are the 10 commandments. Recently I had the opportunity to publish the editorial in the Indian Journal of Orthopedics with your own Dr. Sanjay Keshkar. I met Sanjay Keshkar for the first time yesterday, but Lalit Maini put me across to him, and whatever the manuscript I had written, I passed it on to him. He edited properly so that it is proper for a journal. So there I have written 10 commandments for how to get good results with proximal femoral nailing. So these are the 10 commandments which I am going to discuss one by one. I am not going to read the whole busy slide. Number one point I will take at the end because I don't want to go in a negative manner for the first time itself. Second point is good anti-reduction. Reduction has to be beautiful. Normally we all have been taught the posteromedial combination, posteromedial reduction is one which is very, very important for fracture, intertrochanteric fracture. But I propose the theory that it is not the posteromedial combination, it is the anteromedial reduction which is more important. Because I can see the good anterior cortex. Can you see the posterior cortex? When you cannot see the posterior cortex, how you can reduce the posterior cortex? So what I can see, I can reduce it. Anterior cortex is like the medial tibial condyle, very thick bone. It breaks into few pieces. That's why we fix medial tibial condyle first, then we'll go to the lateral tibial condyle. Lateral tibial condyle is like the posterior cortex, it gets crushed into hundreds of pieces. So reducing its few pieces is much more easier. So reduce the anterior cortex. So it's the reducing the anterior cortex is like putting your first button of your shirt properly. If you put the first button of your shirt properly, automatically the last button or the posterior cortex also will get aligned properly. So I brought the terminology of anterior reduction. Here you can see anterior reduction is not there. Your reduction has to be 100%. When the fracture surfaces overlap, they overlap like this. Even if there is a lack of 25% anterior reduction, there is 25% loss posteriorly. This red area is occupied by the implant, and you have any bone surfaces for union. So reduction is very, very important. This is a picture from 2007. Read this. It's a intraoperative picture, widely displaced fracture. Good morning, sir. Welcome. And what I did, I pushed the neck down, got the reduction, and I fixed the fracture with a K-wire. Then I am making an entry. So this technique, I have been using this since 2003 or 2004. Since I have a Siam which can show the date in 2007, I have got this picture for you. So what I normally do is, if a fracture like this comes to me, I insert a Steinmann pin across the fracture site, elevate the fracture or elevate the neck, whichever requires elevation, then immediately I fix the fracture. Once I get the anterior reduction properly, I fix the fracture with K-wires, and then I put another K-wire. Both of them are very anterior placed in the neck. You can see they are very anterior placed in the neck. For the nail to go and the neck screw to go, there is lot of space down. So once that is done, I adduct the fracture. Since the fracture is fixed, the fracture will not go into varus. If the fracture is not fixed, the superior opening of the fracture happens and fracture goes into varus. So that is the reason why I even fix undisplaced fracture first. You cannot pass a nail without adducting. You have to adduct. If you adduct it, it goes into varus. So to prevent that, fix the fracture with K-wire, then adduct it and do the nailing. So once you adduct the leg, you have lot of place for you to put the nail. A crack fracture like this also, I always fix with K-wire before putting the reamer and the guide wire. Otherwise, the crack fracture, when you put the reamer, gradually opens up, again goes into varus. So always fix all the fractures. There is no excuse. All the fracture fixed with K-wires before you put the guide wire. That's all. Provisional K-wire fixation. This article from Chinese has appeared in 2016. That too for unstable fracture. This is a video. Again, this you can see Yogeshwar Implants video of 11th and 12th June 2005, where I have used this technique.
But I cannot take it off. So image gets distorted.
They both got distorted.
Yeah. For the token, percutaneously guiding.
Can you see? 2 K-wires I have used. K-wires are not used there. That's why I used a 9 inches guide wire to fix the fracture. This was a fracture which was a very stable fracture. And see, you can see still. This is a 2005 video which is still available. You can see this is a very stable fracture. I used the same technique in 2005 which is there in the CD. So this technique, unfortunately, I was not having a friend like Sanjay Keshkar then to present this and get it published. Otherwise this technique would have been Shiva Shankar's technique today. The next point is good medial reduction. Anti-reduction is first, second is good medial reduction. You can see that dotted line medial to that is the compression force, lateral to that is tensile forces are working. Any fracture medial to that line, there has to be good reduction. Especially in subtrochanteric fracture, if there is a huge banana fragment like this, it's better to do encerclage wiring and do the nailing. Coming to the intertrochanteric fractures, there is a beautiful terminology which has been recently given, negative, neutral and positive reductions. The beak of the neck going into the medial canal is negative reduction. Beak touching the neck or the shaft is neutral reduction, and beak going out medially is positive reduction. We should try to aim for positive cortical reduction. This positive cortical reduction not only in AP, even in lateral picture it has to be positive cortical reduction. This is an example of a negative cortical reduction. Any intramedullary implant with the beak going into the medullary canal, always it's varus. With a surface implant like DHS, you can get a valgus. The beak can go into the shaft, but you can get a valgus by using that as a fulcrum in the medullary canal. But with the intramedullary implant, it is always 100% varus. Never accept that. This is a neutral cortical reduction. This is a positive cortical reduction. So I have been talking about this positive cortical reduction for so many years. Here you can see this X-ray. It appears beautifully that it is a positive cortical reduction, but it is only in AP. But if you analyze the lateral picture, the neck is into the medullary canal. It's a negative cortical support, and in due course of time, it has failed. You can see that the beak has slipped inside the medullary canal only because of that. So positive cortical support not only in AP, in lateral view is also very, very important. This is a lesser trochanter avulsion. Whenever there is a lesser trochanter avulsion, get additional 5 degree more valgus so that it will not go toward the nail. See, otherwise it will slip into the medullary canal. So additional 5 degree extra valgus if there is lesser trochanter fracture is there. These are what I have learned by doing all these trials. This was a case one of my friend was operating, Dr. Manmat Raut at Sholapur. When I went, I saw this picture. You can see the beak has gone into the medullary canal. I said, no, we cannot accept this. What I did, I used a bone hook, pulled the trochanter out, got the neutral reduction you can see here, and did the nailing, finished the nailing in that patient. So learn how to get the things out. If the beak is going inside, you should learn how to get it out. By hook or crook, you have to get it out. There is no question of accepting when the beak is inside. This is the immediate postoperative except in the same patient. This is at 4 months. You can see beautifully such a badly comminuted fracture has healed around the nail. Once you get the neck screws properly in the head and neck and nail in the shaft, don't worry about the small pieces. They are all covered with periosteum and muscles. They all fall back together and gum up in due course of time. There is no role for putting them back with screws and wires together in these cases. This is a 2007 X-ray, you can see. A 75-year-old lady where I have got a positive cortical support, a valgus reduction, and this is after 14 months, it's remaining there. The reduction has helped in getting a good union in this patient. Even you can see the screw heads are touching the lateral cortex and there is no further sliding which has happened. This I will talk as the 8th point. Compressing the fracture is also very, very important. Proper position entry is very, very important. Normally, we take the tip of the trochanter as the entry, but unfortunately, the bone lateral to the tip of the trochanter is weak. So, inadvertently, when you put the reamer, you end up reaming easily more on the lateral side. The entry gets lateralized. And this is the proper entry where the neck screws are properly positioned. If the entry gets lateralized, see what happens? The position of the screw which is inferior in the head and neck is also inferior in the neck, which is inferior in the neck is also inferior in the head and neck. But if the entry gets lateralized, the inferior screw already goes center or up. So you will not have proper place to put the second screw. Another thing is, many people think that if there is an intertrochanteric fracture at the entry side, just put the nail through the entry side. When you put a nail through the entry side, the fracture opens up, it acts as a spacer. So you have to make space. If I come to this hall, somebody has to get out and give the place to me if the hall is full. Just because I have come, I cannot just go wherever I want. So similarly, just because a fracture, you should not shovel the nail through the fracture side. If you just put the nail through the fracture side, well, you can see opening up. Varus is happening at the fracture side. See, you have to make space for the nail. Otherwise, the nail will act as a spacer. There is no surface where the fracture is kissing one another and getting the union. Don't expect the osteoblast to jump from here to here and unite. So, never push the nail without properly reaming. Even in elderly osteoporotic bone also, you have to put your 15 millimeter reamer first, then only put the nail. See, this is a 93 or 94-year-old lady I was operating. I have put the entry guide wire. Over that I am enlarging with a curved awl. I am very fond of this curved awl which takes me properly. Here you can see it's 90-year-old written, but actually she was 93-year-old lady. And even in such a osteoporotic bone, I always use the guide wire. Another elderly lady, I am doing the reduction. Once the anterior reduction is beautifully obtained, you can see beautifully obtained by putting a Steinmann pin. I fix the fracture. Once I fix the fracture, I am taking an entry. I am using a 10 millimeter end cutting cheese cutter and making a 10 millimeter hole first in the neck. Then once I have passed the guide wire, I am passing the 15 millimeter reamer. Even in a 93-year-old osteoporotic bone, I am not going for any shortcuts. Then I am using the awl, making a proper hole for the nail. Then I am inserting the nail. Then only you will get the good results. So no shortcut. This is the same lady. You can see at the age of 93, you can see here, this patient is walking with the nail having such a good placement. The next is position of the screw. In AP, it has to be calcar kissing, and it should be in the inferior part of the head. Just because the neck screw is in the neck inferior and it is in the center of the head, not acceptable. The collapse will not happen in the mechanical axis or the direction in which the collapse has to happen. It will not be correct. So, in the lateral picture, it should be in the center or slightly posterior. So, that is the place where you have to be the position of the screw, because this I don't want to discuss too much. Another thing is, we all know about the Baumgartner's TAD distance. They measure from the fovea centralis, the tip of the screw to the fovea centralis in AP and lateral. But as I am advocating, your calcar screw should be as low as possible, kissing the calcar. I want you to measure not the TAD, I want you to measure the calcar TAD. What is calcar TAD? Calcar TAD is extrapolate the screw wherever it touches the articular surface, measure the distance. Instead of measuring from the fovea centralis, measure it from the articular surface. Then your screw should be within 25 millimeter both in AP lateral picture. Then in a 2-screw system, both the screws should be as far as possible at the same horizontal level. The superior screw should never be longer. So if both the screws are at the same horizontal level, both of them take the load simultaneously and slide within the nail easily. If one of the screw is longer, that screw gets jammed. That is the reason why the Z effect or the Z effect happens. This is another beautiful article where they did the screw in different position, both the screw shorter, both the screw longer, one shorter, one longer, like that. Then they came to the conclusion that smooth sliding and least varus malformation happens if both the screws are at the same horizontal level. And there is minimal stress for sliding of the screw at the fracture site and within the nail. So having both the screw at the same horizontal level is very, very important for both the screw to slide easily out of the nail when the fracture requires little collapse. If the superior screw is longer, what happens is the majority of the load is taken by the superior screw. Because the superior screw takes the load, instead of the sliding mechanism, the superior screw gets jammed within the nail. This jamming of the nail causes instead of the vector going out, it starts going down. That becomes the varus force. That is the reason why the superior screw starts cutting out. Because of this varus force, especially if there is a medial void, this jamming will cause the inferior, this varus force will push the screw out, the inferior screw out, and this jamming will cause, whenever the patient lifts the leg, the screw can penetrate inside. So jamming of the superior screw will lead to penetration inside if the superior screw is longer. Even if the jamming doesn't happen or the superior screw is not going inside, it will break at the junction of threaded and non-threaded portion. So analyze all your PFN X-rays. If your superior screw has broken at the junction of threaded and non-threaded portion, if you go back to the immediate post-operative X-ray, always you will find the superior screw was longer than the inferior. So these all the analysis I have done over so many years, and I am giving you the final cookbook to you, the result, how to do. Well compressed fracture. As I said earlier, you can see on table, I have achieved a good compression in a 75-year-old lady, and at 14 months, the screws are not sliding back. So you have to compress whatever the fracture begs for. Don't over compress and lose the purchase of the screw. So you are feeling you should get how much you are tightening the screw, the lag effect, you should be able to measure it. How we normally measure this? How I do a PFN normally is, how I measure normally this compression is, not measure, how I do compress this fracture.
I have passed both the screws and I will alternately compact both the cervical screw and the derotational screw. That will compact the fracture and the screw will not be lying outside, and this will prevent Z effect.
So this is very, very important. And this is another X-ray. You can see the screw heads are touching the lateral wall. At 4 months, they are still there. So this you have to compress the fracture on table, whatever it is begging for. Recently in March, I was with Rajiv Raman in Kolkata for the mini IOCon, Jaipur. And on that day, in my hospital, a surgery was done in my absence. And this was the patient who was operated on 6th of March. My assistant, OT assistant, asked me to send a message to get this. These are the implants used. I have my own set. Whatever the implant I use, I send to the company and get the implants replaced from them. So he sent me a message, inferior screw 8 millimeter screw, 105 millimeter. This immediately struck to my mind. 105 millimeter in Indian patients, especially anybody less than 6 feet tall, is not required. Since On 4th March, before I left, I had seen this patient in my hospital. I knew this is something wrong. So immediately I wrote to my assistant, Dr. Sachin Kulkarni, today's operated case, my guess is foot and traction was not released before fully tightening the screw. Once I see the post-operative X-ray, let's discuss. 6th March immediately, as soon as I saw this message, 12:39 he had sent the message, and as soon as I saw the message, immediately I sent a message to my operating surgeon, and he shared the X-ray on 8th of March. I was still in Jaipur. You can see the screw heads are not touching the lateral wall. Compression is not achieved on the table. Unfortunately, there is also negative cortical reduction. It is a invitation for failure. Unfortunately, when I said we have to correct, the patient said no, he is not having any trouble, so he did not agree for that. In due course of time, you can see the superior screw has broken. Can you see? And it has much more sliding out. So this is what you should, by seeing your X-ray, you should be in a position to tell these are the things. Coming to the comminuted lateral wall fractures. The first video was working, but unfortunately none of the videos are working. That's fine anyway, it doesn't matter. Comminuted lateral wall fracture is another thing which is very, very important. We all know if the lateral wall is less than 20 millimeter or 20.5 millimeter, DHS is contraindicated. So whenever there is lateral wall comminuted fracture, if you are using a nail, Dr. Naveen Thakkar and Dr. Shashikant Ganjale from Sholapur have come out with a trochanteric buttress plate. Dr. Sushrut Babulkar from Nagpur and Sunil Kulkarni from Miraj, they have published a paper of trochanter wiring. But I have my own technique of tackling the lateral wall problem, which I am going to share. This is Dr. Naveen Thakkar's trochanteric buttress plate, where he uses a recon nail. Over that he passes the plate and the guide wire, and the nail is passed. This is Dr. Shashikant Ganchale's trochanteric buttress plate, where you can see that lateral wall, if there is a fracture, you can use this plate itself as the lateral wall, and they will act as the lateral wall, and they will support the comminuted fracture. This is the wiring technique of Dr. Sushrut Babulkar and Sunil Kulkarni, where they bundle all the fragments together and use this. I have published a paper along with Dr. Gadegune. If the lateral wall is big enough, you fix that fracture just with a screw, that is sufficient. But if the fracture is big enough, the lateral wall is big enough, then you can fix that with a screw like this. If there is intertrochanteric fracture with a subtrochanteric fracture, then intertrochanteric fracture can be fixed with a screw, convert the intertrochanteric fracture into a subtrochanteric fracture, and then carry out the nail. This is another way of treating a intertrochanteric fracture. If there is a large banana fragment medially, always use a wiring, because this area you cannot have a gap. This is the weight bearing axis in the medial aspect along the calcar. Always put them back by wire. If the fracture is comminuted like this, you can put them together by wiring or even by plate like this. So this wiring as well as the plate I have used in this patient, and recently this patient had come. I have shared the X-rays last week with many of you on my personal chat. This is the trochanteric buttress plate. The patient had an excellent outcome, you can see. If there is a lot of combination, but there is a large chunk. This was the case I operated during Ganga operative trauma course. This was the case I was given to operate. You can see that I was able to get the purchase of the screw head in the lateral wall, so I had just managed with a nail and a plate. If there is a badly comminuted fracture, this is where I am coming. I have given all the examples. In this case, what I do is, I will not look into the comminution. What I do is, I use the nail itself as a lateral wall. You can see the screw heads are touching the nail. I am going through the fracture site, through all the comminution. Screw head requires support. If the screw head is not having support, it will slide out. So compress against the nail itself. This is after 4.5 years, there is no problem. As long as you have got a good valgus reduction. If you are in valgus, it is not going to work. Getting 5 degree extra valgus and getting the screw head touching the nail is the crux of the treatment in these cases. This was a case I was demonstrating at Pune Trauma Course at Sancheti Hospital. You can see there is a lesser trochanter avulsion as well as fracture of the lateral wall where I am passing the screw. What I did was I used a nail. Because there is lesser trochanter avulsion, I have got a 5° extra valgus. Because there is lateral wall avulsion, I have used the screw head touching the nail. Just at 1 month, you can see Sancheti Institute of Orthopedic Sciences. This patient, already the fracture is united. Atul Patil, the trauma head, shared me this picture just at 1 month time. If you get the alignment right, you can, even in badly comminuted fractures, you can get away just with a PFN. This is what I call it as Shiva's technique of tackling lateral wall deficiency. This is unpublished data. I am only sharing with you all people. Another case, severely badly comminuted fractures. You can see that the head of the screws are touching the nail. This is after the implants have been removed. Beautifully the fracture has united in valgus. This is what I tell. The lateral wall, the screw head requires the support of the lateral wall. If the lateral wall is not touching the screw head or the screw head is not supported, it can toggle like this. This toggling can lead to loss of purchase of the screws and sliding out in due course of time. That is the reason why almost 40% of the transcervical fractures treated just with screw will have screw backing out or failing. That is the reason why nowadays we use a Powell screw or we even use a fully threaded screws. You are with me? So here you can see the screw heads are not touching the lateral wall. This is going to fail in due course of time. That is the reason why we take out 1 or 2 partly threaded screws and fix with fully threaded screws at the end. That is the reason why for a transcervical fracture we use a Powell screw. We don't want undue collapse to happen. If undue collapse happens, the screw head will lose the support of the lateral wall and start dangling, and it will slide out, leading to failure. So this is about screw having a lateral wall support. If the lateral wall is missing or osteoporotic fracture like this is a 85-year-old man, you can see. There is lateral wall is missing or osteoporotic, by screw heads are touching the nail, and this patient is walking in the immediate postoperative period, and this is at 10 weeks when he came for follow-up. You can see that screw heads are still touching the nail. 85-year-old osteoporotic bone, no sliding has happened, not even a millimeter of sliding has happened. The patient thought that he is not going to live because his friends and his same age people in the town, all of them died with a hip fracture. When he came to me, he was literally crying. You can see the tears in his eyes, and he was thanking profusely for doing this wonderful job. Understanding the fracture is very, very important. This is what I showed earlier. During Ganga operative trauma course, I did the nailing in this 75-year-old lady, and the fracture has beautifully united. This is after 3.5 years. There is some sliding which is there because I used the imported set. I opened the screw. The screw was little long. I didn't want to change it. Otherwise, unnecessarily, the patient has to pay few more $1,000 for this imported system I was using at that time. So, otherwise, when we use the Indian implant, I don't mind take out and I insert a proper little shorter screw. We have the technique of the newer nails where they can compress by pushing the screw out. By pulling the screw out, so that video is not there. Anyway, fine. So what happens is the outer wall, outer sleeve, you can, when you tighten that round nut here, the sleeve pushes. When the sleeve is pushing, the screw will come out. That will compress the fracture. When the fracture is compressed, you lock from the top and release it. So this is the system. Almost all the newer nails I have got, the single screw system nails I have got. This was what I was using. What I did, I used a lag screw type of system. I compressed on table and I inserted the set screw from the top. As soon as I released, you can see the fracture opening up. I have put the set screw on the top. In spite of that, the fracture which was so tightly compressed here is opening up. Can you see this? This is because there is no support of the head. The screw can slide inside. None of the newer system which is available in the market now have got a head. Because of that, they slide inside. Whatever the compression you achieve on table may not be retained. Even if the set screw becomes little loose, the screw will move inside and they will not do the work. So I have shown all these cases where just by the screw heads against the nail I have been able to tackle. Fortunately, this nail and the screw, I have been able to design this in 1999. None of the newer screw have got Gamma nail, PFN A2, Trigen nail, ZNN, Halifax. None of them have got the head. So if you use for comminuted fracture any of them, you cannot use my technique. You have to either use the plate or put the wire or do something else. It's okay for a stable fracture, they work well. I am going to demonstrate a stable fracture today thanks to both Joydeep and Raman, Rajiv. They have kept a very simple case for me. I can use any of the implant and get away. But if it was badly comminuted fracture, I would have said I will not do PFN A2. I only want PFN or TFN. I hope you are with me. The ninth point is screw at the entry side should be slightly up at the entry side. It has to be outside. If it goes inside, again, you can see uncontrolled medialization can happen. This is Dr. Mukesh Agarwal from Guwahati shared me this picture. You can see the tip of the nail has gone inside. In due course of time, it can toggle inside. There is no support for the top of the nail. There are 3 points which are very, very important. Entry, screw site and distal fit. These are the 3 points where a nail has got the fixation. If any one of them is missing, you are going to have a failure. More or less failure, because 100% may not failure may not happen. So if you are using a nail, if it is short, you should build up with a head or a top screw. So the screw should be, you should always feel at the end of the surgery, either with a C-arm or with your finger, that your screw nail is slightly out at the entry side. That is also very, very important. 10th one is in headless screw. As I said earlier, I don't like to use a headless screw. But if you are using a headless screw for whatever the reason, back end of the screw should be slightly out of the lateral cortex so that they can slide out when the fracture collapses. If it is inside like this, they cannot collapse. This is a mistake I did myself in my own hospital. You can see the back end of the screw has gone inside. I tried to compress the fracture and lock it, but unfortunately at the end of the surgery, when I realized that the back end of the screw is outside. What it can cause? If the back end of the screw is outside, it can slide out. If the back end of the screw is inside, the hole in the lateral wall may not match with the screw, so penetration chances are very, very high. That is the reason why when PFN-A came in the market, penetration was very, very high. Because we were hammering the nail as inside as possible at that time. Now we know that we have to keep the back end of the screw slightly outside. This is Dr. Joydeep Das from Burdwan Medical College, your own area. He shared me on 14th of July. Since he told me, I am concerned, 65-year-old lady did last week, please comment sir, the helical blade had crossed the safety limit. Will it perforate or back out? He asked me a question on 14th of July, will it perforate or back out? I immediately wrote back saying that since the back end of the helical blade is out of the lateral cortex, penetration chances are less and sliding out chances are more. Unless sliding gets jammed for whatever the reason, the chances are less than 10%. You can see that I have given a 90% chance that it will not have a penetration. Exactly 1 year back on 5th of September, Joydeep writes to me, 6 week post-operative, as predicted, sir, no cutout. Happy Teachers Day. This is what I want you to predict. Why Joydeep has to write to me and ask me? If you know all these points, you yourself can predict that whether your implant is going to survive or not. learn to predict the outcome by knowing sufficiency or deficiency. If all the 10 points are covered properly in your case, 100% sure that it is going to unite. If 1 or 2 is going to be bad, 90% it will unite. If there are more than 3 which are out, then 50% failure. So you should be able to predict it. The last point, or the first point, I didn't want to use this as the first point, that's why I used it as the last point. Good implant from a good company, not a poor copy. There are many companies which sell substandard nails in India because we don't have anybody who takes care of the quality of the implant. Sir, this nail fits to AO set or Synthus nail set. Use this. This is only 2,000 rupees nail. We all use them and we'll burn our fingers because substandard implants are available in Lohar Chal of Bombay at a very throw-away price. They are not gun drill nail. They are manufactured by tube, the seamless tube. The wall thickness is less. The design is poor. They are bent, hammered so many times to make the shape so that they are already stressed out. So they break very easily. See, PFN came in the market to avoid the locking too near the tip of the nail to avoid stress riser. But here you can see a manufacturer gives a nail with a interlocking to be done at the tip of the nail. PFN with a tapered end to avoid stress riser. See the thickness of the distal end of the nail. There is a peri-implant fracture because there is too stiff. Around the nail bound to happen. See the screw heads. They are not of proper shape and size. This is a proper copy of Indian implant which I have been able to design. See the tapering. When you are inserting, the stress will not happen in the bone joint, and see the distance at which we do the interlocking. We are doing 1.5 inch away from the tip so that on a wider area the stress is distributed. So this is the implant, the Atmanirbhar implant. See the end result. Instead of a 15 millimeter nail, some company has manufactured, some surgeon wanted a thinner nail, 13 millimeter nail. It has already broken because there is hardly any metal on either side at the whole side. So it's bound to break. So these are the 10 points which if you are taking care, definitely you will have beautiful results. I'll just end the talk with few cases. Again, this Dr. Yogendra Singh Shekhawat shared this X-ray. Again, you can see the lateral wall has penetrated. I asked him to share the subsequent pictures, but he has not shared the picture with me. So the back end of the screw should be outside. This is Kota Yelluru, Aditya from Yelluru. When I went to Osapkan, the next day he shared me the picture. Sir, after your talk, I was able to do the case. He was very joyous. Operated this case today, sir. Immediately he sent me the picture. And he shared this picture with me. There are so many problems with this. The entry should have been from medial to the GT. Little more valgus was required. You can see there is varus reduction. Then there is medial gap, so valgus, additional valgus is required. Cervical screw is inferior in the neck, but should be in the inferior head also, but it is already in the central portion, means again it indicates there is varus. Never use fracture site as the entry site because you can see the nail is acting as a spacer at the fracture site. I asked him to send the pelvis with both X-ray, but he has not sent me. This is an elderly lady with hardly any posterior cortex. You can see there is such a huge gap. I did the Halifax nail in this patient, and this patient you can see beautifully it has healed at 1 month's time, 3 months time. The posterior where there was no bone, the bone has formed. This is at 8 months follow-up. It's remaining at the same place. Fracture is united beautifully. This I didn't do in my own setup. I went to Baramati where Sharad Pawar hails from. One of our orthopedic surgeons' grandfather had this fracture. 86-year-old man with a fracture. You can see I'm using the nail itself as a lateral wall. I did about 3 years back in 2018, I think. Yeah, October 2018. This is 8 weeks post-operative picture. Again, I went on 8th June this year only to operate another patient of the same family. That time he came to felicitate me, and you can see the neck shaft angle beautifully restored, and the patient was walking without any problem. I'll show the picture because I want you to see the patient walking without any problem. This is an 89-year-old person walking unsupported in home. Whenever he goes out of the house, he uses a stick for support. So, age is not the indication. Doing surgery properly is the indication for doing PFN. Okay, that's the last thing I wanted to say. Thank you very much. If there are any question, I will take so that I can. Yeah. Okay, fine. Yes, fine. Thank you. Yes. Yeah. Yes, it's fine.
Thank you.
So we have with us our President-elect, Dr. Chandan Pathak, sir. So, sir, tell a few words for the gathering.
Okay, I don't want to burden you with any comment, and I really sincerely thank Rajiv and JBCH and WBA whole team to organize and bring Dr. Shiva Shankar for this today's clinical meeting or sort of CME. And this lecture, it's this 10 commandments possibly he has published, and it's due to be published in a proper way, but this is in the process of publication of Dr. Shiva Shankar. And possibly in India, he is one of the most learned person regarding management of trochanteric fracture since for last 35 to 40 years almost. He is dedicated to this subject. So I think we'll all learn from him and take interactive part in this live demonstration. Thank you.
So we'll invite our past president, Professor Dilip Majumdar sir, to chair the session. Sir, please.
So very good morning to all of you. Now the lecture is by Dr. Soumitra Mishra. So he will talk about fracture neck femur. Trochanteric fracture. Okay.
I think after this elaborate talk by Dr. Shiva Shankar, my talk has very little relevance because he has covered everything. I'll probably say less than what he talked. This is about decision making in intertrochanteric fractures. Now, let's take this patient who is a 90-year-old female, domestic fall with diabetes and hypertension on aspirin. These are typical patients which we treat day in and day out. So we'll plan for how do we plan for this patient? Can anybody from behind would think about treating this fracture conservatively? Is there any role of conservative treatment? Can you tell any indication for conservative treatment in trochanteric fracture? They do not refuse in hip fractures. Now there are certain indications written in the book. If the life expectancy of the patient is less than 6 weeks, if the patient is severely demented and the pain can be controlled, and if the fracture is detected in MRI, in those cases probably you can treat conservatively, but there is no other role of treating these fractures conservatively. So success or failure depends on many factors. Now there are certain factors which are beyond our control. We cannot control these factors, like osteoporosis, like fracture comminution. Posterior void has been so nicely elaborated, and the lateral wall. And what it causes actually, they causes our reduction difficult, they causes poor hold of the implant, whereas uncontrolled collapse and implant cutout. So what do you mean by stable fracture? Stable fracture is a two-part undisplaced or displaced fracture, or if there is a small lesser trochanteric fragment. These are stable fractures. Rest are all unstable. Unstable is if there is more than three or more fragment, if there is a large posterior fragment, if there is a shattered lateral wall as described by Gottfried, if there is a fracture in the subtrochanteric extension, it has gone below the lesser trochanter, if it is a reverse oblique, completely different ball game. And if there is extension in the neck as described by Kiles, this is again a more severe fracture where probably you cannot fix them at all. Now coming to the importance of posterior fragment, again the repetition what Dr. Shiva Shankar said, this is the very strong bone. Posterior is a very strong bone, part of the calcar, and it lies in the weight bearing line. So if there is a weight bearing line fragment is broken, so your compression side is broken, you have a tension side on the lateral side, so any DHS you put on the lateral side, you need an intact medial fragment, otherwise the tension device will fail. That's why in a very large posterior fragment, DHS has got a tendency to fail, and that leads to varus. What is the importance of lateral wall? When the lateral wall is comminuted, there is uncontrolled collapse, and the distal fragment just moves, keep on moving medially until it stops. Now this is a very interesting paper which describes the importance of lateral wall. From the innominate tubercle of the trochanter, if you go 3 cm down, and that at 135-degree angle, if you measure the lateral wall thickness, that is the measurement we take, and if it is less than 20.5, that is the critical value is less than 20.5 millimeter, then the lateral wall is deficient. Now this deficient lateral wall, if you try to do a DHS, if it is less than 25 mm, it has been seen that most of these cases you create a iatrogenic lateral wall failure. I will show you by example. Say this fracture done by me only. This is a 89-year-old lady. See the lateral wall below the 3.3 cm below the innominate tubercle. So you see there, this is definitely less than 20.5 millimeter. I did a DHS. You see what I have done. I have broken the lateral cortex at the time of doing DHS. And see the end result. I am lucky that this lady has united. You can see the amount of medial displacement. You can see the amount of collapse, sliding. I'll show you later how you can prevent this. So again, there are certain factors which we can control, which is in our hand. Very clearly said in the 10 commandments. That identification factor, there is a stable or an unstable variety. You can control the reduction, you can select your implant, and you can treat the osteoporosis. All these factors are in your hand, you can control these. Now, so we all know about the AO classification. We know that A1, 2, 3, and probably A2.1, these are less comminuted or two fragment or maybe a small lesser trochanter, so they are stable, and the rest are unstable. So all in the green are stable fractures, and all in the red are unstable fractures. As we go from left to right and above down, the stability decreases. So what is a desirable reduction has been very clearly said, nothing new to say. You need a good bone-to-bone contact. And where do you need the contact? The only intact and good bone is anteriorly and medially. That's the area, anteromedially. That's the area which you will have to target, that where you have to get a good bone-to-bone contact. Now before the DHS came, we used to, all used to use a fixed angle device. There was no sliding. When the DHS came, then you know that sliding is very important. That as the sliding occurs in a cancellous bone, sliding leads to union, helps to union. But later we came to understand the sliding is the peril in the trochanteric fracture. If there is excessive slide, that will lead to failure. We do not want excessive slide. We need slide at a certain extent, but not excessive slide. You actually may not require a slide at all if you have a good bone-to-bone contact and good compression at the initial stage of the surgery. You will not require any sliding at all for the fracture to unite. Now, where do we need the reduction? Anterior and medial cortical contract. You know now what is a positive reduction, neutral reduction, or negative reduction. I will show you in a picture. Now, if you see the top picture, you see that is the medial wall, and now this is the positive reduction. The medial is outside the medial proximal is outside the medial distal. Then this is the neutral, and if it is inside, then it is a negative reduction. Same anteriorly, if the anterior proximal is anterior to the anterior distal, that is positive. If it is in line, that is neutral. If it is inside, then it is negative. Now, showing this example, what happens if you achieve a negative reduction? See on the top, that is a negative reduction. As the implant slides further, fracture will go into varus. Now, as it goes into varus, the screw will cut out, nail screw will cut out. But in the lower picture, with a positive reduction, this will not slide further. Sliding will be limited. You do not want excessive collapse. You do not want excessive slide. You need just the minimum amount of contact and compression across the fracture side. And that positive reduction will help you. That sliding will stop at that point of time, and the fracture will bend. So in spite of having a good big posteromedial chunk, with a good anteromedial reduction, you can have a very, very good outcome of the fracture. Now coming back to our patient, who was a 90-year-old lady, you can see on the fracture table, the reduction is like this. So this is a negative anterior, negative medial. So you need to correct that by positive anterior. Now it's a positive anterior, positive medial. You hold it correctly, then you can put any implant. Again, another example. You can see there is a posterior shagging of the distal fragment. So you correct that, get positive anterior, positive medial. Now you can put your implant. There are umpteen number of papers on this reduction technique, on this reduction, advantage of this reduction. Positive medial, ultimately the positive reduction leads to less sliding. So it gives a secondary stability and a good mechanical environment for healing. Now shattered lateral wall, again you have seen so many examples on Dr. Shiva Shankar, how you can correct that by a trochanteric stabilization plate, tension band wire, intermedullary nail, derotation screw, all been described. Like in this lady I showed you that I have broken the lateral cortex, so much sliding that could have been prevented very well by putting a trochanteric stabilization plate. So what I have done in the next case, done a DHS, though it's an intact wall, I prophylactically put a trochanteric stabilization plate and it has united without any complication. So trochanteric stabilization improves the treatment outcome in 3-1-A2 fracture. So we are not worried till about 3-1-A1. From A2 the worry comes. Up to A1 anything works. A1, all A and A2.1 all are stable, so you don't need to worry about the implant. So again
पहले पर अच्छा था ठीक है yes
ठीक है ठीक है
again with a broken lateral wall you can do with a nail only, or you can use a kind of plate which is a non-sliding implant. Very shattered lateral wall, you can use a completely non-sliding implant. Posterior defect you can correct by bone graft, bone substitute, or you can screw the posterior fragment. But again, the importance is the anterior medial reduction. Now selection of implants. As I said that from all A1 and A2 2.1, you can use all implants. Nowadays, people are really forgot using the DHS. But what I can say that this A1 and supporting arthroplasty thoracic fracture. Again, you need to correct the general measures like good nutrition, vitamin D, management of osteoporosis, immune prophylaxis, and a good rehab. Coming back to our patient, which we achieved positive anterior and positive medial reduction, then you can fix it with any device you want. I use the JHS with the documented stabilization plate, but you can use up EFF as well in this fracture. So what we take home from here, we need to identify the unstable pattern. We need to talk about the medial and think about lateral and medial wall integrity or when you are looking at the X-ray. Do a good reduction, a positive anteromedial reduction is the crux of success. Select the proper implant depending on your fracture pattern, do a good rehab and treat osteoporosis. Thank you very much.
So thank you, Dr. Misra. Actually, you have done a very good package because after the Mahabharata that Shiva Shankar told about everything all over the country, cases from all over the country he has shown. And we know him from last 30 years, what he is doing. But what you have done an excellent job of making a beautiful package of what he has told. Very nice. And you must bring this thing to the minds of the youngsters regarding the three things. Number one,
draping.
Void lateral.
You have any disposable drape or we are
void
drape
lateral.
or something like that?
Number one, the void lateral. Number two, the medial banana.
We'll put this first. You
Medial
have towels?
banana. And number three is this
Get some hot
nail
towels.
touching to the screw
Towels,
touching
towel.
to the nail, because there is no outer wall. So these three things, and lastly the reversibly. These three things you should highlight more. Thank you very much. Yeah. So thank you. Any other question, please? Thank you. Thank you, Mr. Dr. Misra.
Now we will go live to the operating theatre. So Dr. Arnav Karnakar will moderate the session. Over to you, Arnav.
I was doing that for that only. I thought you were putting on the rod. Towel clip. Okay, hip you drape.
Hello.
Yes, can you hear me?
Yes, sir.
Videographer.
Yes. So could you please show the X-ray first? And with the X-ray, you want Dr. Shiva Shankar's opinion and planning on that case before we go on the operation.
Don't turn. Don't turn. Somebody has to come from that side. Where is this? Take. 1 minute, 1 minute, 1 minute. Don't be in a hurry. लीजिए 1 minute. ओके हाँ ड्रॉप कर दीजिए. दिस उल्टा सॉरी. Okay. Can you see?
Yes, sir.
Hello.
Yeah.
This is a stable fracture. I don't think I require any manipulation to be done. I just fix the fracture. K-wire we drill.
Okay.
As I said earlier, और भी पतला चाहिए. 2.5 mm K-wire. This is too long. K-wire 6 inches. Tushar, I think you are in the hall listening to them.
Yes.
Tushar Pandya. I am waiting for the K-wire, 2 mm or 2.5 mm K-wire. Because I have been given, इधर दिखाओ सर. भैया ऑपरेशन दिखाने का है. एक्सरे कितना देर दिखाते हैं? इधर आ जाइए. थोड़ा जगह छोड़िए उनको. उधर से पीछे से.
Sir, do you do any reduction maneuver?
Do you think that there is reduction required here?
No. This case
that,
is very yeah. But
this is too thin.
As we get the chance, if you can just show us how you put the statement pin to reduce it.
Next size.
Just for show it.
Wire cutter भी चाहिए. So here what I am going to do is just fix the fracture because the leg is in neutral position right now. I want to adduct it.
Okay.
So you can see that in the C-arm, I will not be able to push the nail medial to the tip of the trochanter. Okay. Or if I try to do anything, I'll enter through the fracture side. So to avoid that, I'll first fix the fracture, adduct the limb. Another thing what I want to show is, I have kept the perineal post eccentrically.
Okay. So please the cameraman show it.
It is not possible because already I have done the draping.
Okay.
I'll just show. See, my thumb is on the medial part of the perineal post. This is the perineal post. Can you see this?
Yeah.
So there is a gap of almost 2 inches between that. Okay. Once I fix the fracture, I am going to adduct it.
Okay.
Yeah. Wire cutter. One side cut. Yes. Yes, you can put that in the drill.
Hello, sir. Shiva Shankar, sir. Can
Yes.
you hear me? Yeah, I'm Sunit, sir. I just wanted to ask you, all your reduction maneuvers are mainly percutaneous, or when you require reduction, you mostly do the percutaneous reduction, or you sometimes do the open reduction as well?
I am yet to do a open reduction so far. I always do with the Steinman pin. I insert the Steinman pin at the fracture site and just elevate. What I do is I'll just show how I normally do. Give me one Steinman pin. Give me Steinman pin. So what I do is I take the Steinman pin, insert at the fracture site and manipulate. The femoral artery is here. My entry is at least about 3 to 4 inch away from this. So I pierce this Steinman pin, enter into the fracture site. If the neck is like this, I enter in and I will remove the like this.
Okay, sir.
I am waiting for the KY to fix the fracture.
But majority of the fractures, sir, if you see, the distal fragment is actually hanging down.
Yes.
And the proximal part is little up.
Correct, correct. Except where there is lesser trochanter attached to the distal fragment, where the neck will be hanging down and the shaft will be up.
So what is your reduction maneuver on that?
Same. Yeah. Leave this. Okay, what? Give now. Okay. Shoot. I want to see the level at which I want
Sir,
to.
Our secretary wants to ask you a question.
Yes, Partha.
Sir, there is a problem. As I am also wearing spectacles. I am watching that your spectacle is full of moist fogging. How to manage this fogging?
You go to Titan Plus. They have got a fog-free spectacle which is available. I'm right now using the fog-free also, but even then it's not 100% fog-free, but it is better. Otherwise, मेरे चेहरे के ऊपर करो. You can see that I have put a small sticking plaster just in front above my nose.
Yes, sir.
So that is another way. So what I am going to do is, अभी इधर focus करो. I am using a K wire, slipping it anteriorly. You can see I am withdrawing again, and I am on the anterior cortex, anterolateral cortex, just making an entry. Shoot. The direction is little inferior. See, I am slipping anteriorly. Shoot. The quality is not holding it properly. It's slipping only. Shoot. It has okay. It has pierced at last. You take it in lateral view. Now you can see that. Can you see the CM picture?
Yes, we can.
Okay. See, I have entered the lateral cortex. Now keeping the CM, जितना नजदीक है उतना नजदीक लेके आई है. Now keeping the CM in lateral view, I will go as anteriorly as possible within the bone. Shoot. Thoda distally. Yes. Shoot.
So we are not seeing the now it's okay.
Shoot. This collet is not working, madam. The drill is not holding the wire. Okay. No, it's also not holding. Shoot. You can take thicker wire. Get 2 millimeter wire, please. 2.5 millimeter wire. वो तो बहुत बड़ा हो गया. See, the problem right now I am facing is the drill collet is not properly fixing with the wire, and it is only slipping over the K wire. this is too thick, but anyway I am okay with this at present because shoot. Shoot. I want to go slightly up also. Shoot. It's going in the same direction. Shoot. 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 Okay. Chavi key. Now you can see that they are going anteriorly. Out tight karo aur thoda. Aur ek wire do, but not this. They have given the Steinman pin almost 4 millimeter thick. I don't want such a thick thing. Shoot. Okay, it has pierced medially the neck. इसको टाइट कर दीजिए. नहीं टाइट कर दीजिए. इसको ही डाल देंगे बस. 1 मिनट. Leave. Tight. Shoot. Shoot. It's touching the medial part of the neck. AP. Just to confirm, because they are not going to the head, that indicate that they are touching the neck medially. The thicker wire has already pierced the medial cortex. The thinner wire, the inferior wire, is going to pierce now, which I will show now.
Show the CM picture.
See
we are
now.
not able to see.
Can you see now?
No, sir. The camera man, please show the CM picture.
Camera, CM picture दिखाइए. Shoot. Shoot. Okay. Lateral view. You have seen the camera picture?
Yes, sir.
Yes.
Now we can see.
Yes. Now I'll show the lateral picture because the wire which was inferior I have applied superiorly.
Okay. So both of these wires are anteriorly?
Very anteriorly placed.
Okay.
I am happy with this position, this lateral view. निकल दीजिए. Now, अभी zoom out कीजिए पूरा leg दिखाने का, adduct करने का. Who is going to adduct the leg? इधर से नीचे से. Can you see? Hello.
Yes, sir. We can see.
Mic is, I think, slipping from my neck. See, so much of adduction is possible.
Right.
Okay.
Yeah.
I'll just, there is some distraction inferiorly. I push the fragment by manipulation, just like this.
Okay.
That will again reduce the gap. AP. Again AP. You right now you see the picture on the right side. I'll take a picture now. The gap will be less now.
Okay.
Shoot. Can you see on the left side now?
Yes.
Gap has reduced.
Yeah.
And there is adduction also has been done. Now, taking an entry, marking pen is there. Otherwise, you give the knife. That's fine. मेरा गिर रहा है क्या कान के ऊपर से? अच्छा है? ठीक है. See, this is the anterior superior iliac spine. Okay. A line dropping down directly. This is the anterior cortex of the neck, the tip of the trochanter, a line going vertically. Wherever they meet, take the incision and extend it distally.
Okay.
This is about 1.5 to 2 inch long incision, and if required we will enlarge it afterwards.
Right.
Shoot. you can see my finger going medial to the tip of the trochanter. और थोड़ा adduction कर सकते हैं क्या? I will increase the incision distally little because it is little tight knife. Entry pin. Now I am taking an entry. I am using my index finger and I know the place where I am keeping. Shoot. थोड़ा ऊपर.
Show the CM picture.
Shoot. There is a fracture of the tip of the trochanter. That's why it's appearing like that. I will go on the neck now. Shoot. See? Can you see the CM picture? Dikha udhar?
Yeah, yes sir, we can see.
Okay. Now I'll see the lateral picture before inserting further. Shoot. Okay. Lateral. Oh, एक मिनट आगे ढक लो. आप एक स्टूल के ऊपर खड़े हो जाए और थोड़ा ऊपर कर दीजिए. एक स्टूल के ऊपर खड़ा हो जाइए. टेबल अप नहीं, टेबल डाउन हो सके तो. ओके. थोड़ा सीएम और थोड़ा आगे जा सकते हैं. मुझे इधर काम करने के लिए जगह नहीं है. नहीं, और भी थोड़ा पुश. नहीं, इधर काम करने के लिए जगह नहीं हो रहा. एपी कर दो वापस. बस बस. Shoot. This. Shoot. Okay. Hammer. अभी इसी और टेक्नीशियन इसको टच नहीं करते हुए लैटरल दिखाने का हैमर करो. ओके, 1 मिनट इसको निकाल ही देंगे. और थोड़ा हैमर कर दो. ओके, बस. अभी लैटरल दिखाओ. यस. आउल, सेंटरिंग आउल दीजिए अभी. स्लीव. शूट. बहुत एंटीरियर हो गया. शूट. यस. हैमर. हैमर कीजिए. See, this is very, very important. Shoot. In the lateral, it has to be exactly in the center.
Yes.
अभी एपी कर दो, बस हो गया. सेंटरिंग आउल. ये है कि दूसरा कुछ है क्या? रीमिंग, सेंटरिंग, रीमर. हाँ. स्लीव, प्रोटेक्टर स्लीव. अभी नाइफ दीजिए. So once I pass the guide wire, sir, you are coming in the way. Once I pass the guide wire, knife. I just take an incision again over the guide wire and split the soft tissue up to the entry site. Then I'll insert the protector sleeve. And now I insert the centering awl, hand trimmer के ऊपर. So this is the centering awl, which is reaming for the proximal end Again you can see I am pushing on the left side, shoot. My pressure is always trying to remove the medial side, otherwise the osteoporotic bone you will break easily on the lateral side.
Siam view, AP view, we need to see that.
Shoot.
Siam picture, AP. Yes.
Okay. Now guide wire thoda पीछे लीजिए. See, now I have made an entry. What I am going to do is, I want to go parallel to the lateral cortex. ज़्यादा मत निकालिए. Shoot. Yes. और थोड़ा निकालिए. निकाल दीजिए बस. ठीक है. नहीं बस. ठीक है. नहीं out नहीं. Shoot. Now we can see I removed the guide pin. इधर दिखाइए please. Cameraman. ये this I am pushing it medially.
Yes, sir.
And that will take my reamer parallel to the lateral cortex into the distal canal. Shoot. Can you see?
Yes, yes, you can.
And I will ream. आपका हाथ आ रहा है. Till this stopper touches the sleeve.
Okay.
Shoot and save. So this is for the proximal nail part I have reamed. Now what I am going to do is, I long guide wire. I take out this guide pin. I insert the long guide wire into the medullary canal. Shoot. Okay.
Yes, sir. Okay.
Yes. Now the nail. Short nail. 11 mm nail. अब रख दीजिए, छोड़ दीजिए.
Sir, do you
See,
normally use the carved doll? Ever used it, or this is the way you always do?
I normally use this. See, you can show here. आप इधर जगह छोड़ दीजिए. See, I normally use this first.
Okay.
I don't directly use the centering awl, but now it is a different setup. Too many people around me here, so I use this tip. Now I am assembling the nail again. As you can see, the people here, they are more interested to see for themselves rather than to show you. I am getting the nail assembled. It's a short PFN I am using. Yes. If you want me to demonstrate, where is that? Lag screw, I'll use the lag screw. If you want me to demonstrate that PFNA2, I'll demonstrate the PFNA2, because this hybrid nail can accommodate both the screws.
Okay, sir.
Okay.
Okay.
Then just to confirm that they are working properly, because I should not blame somebody afterwards. You can see that it's going exactly in the center, not an issue. Okay. Okay?
Okay, sir.
Anyway, I want you to tell me right now whether I should use the lag screw or a PFNA2. Well, you are inserting the nail, flex and adduct, because many a time this nail touches the medial part. So to do that, make it easy, you do this. Shoot. Then I am removing the guide wire. There should be a hammer here. Instrument to fix this. You are totally blocking. Yes, that should be enough. The incision is little small. Normally I apply this and push this, but today, because since long time I have not used this, to tell frankly. Tight करने के लिए दीजिए.
The diameter of the nail is 10.
11.
11. So do you ream the canal also sometime? Especially
very
in
rarely in young patient I ream the canal, or if I am using a long PFN I always ream, but for short PFN I never ream it.
Sister, mop দেবেন তো?
Okay, enough. Rod. Shoot. Okay, this is enough. Rod is not required. Shoot. Okay. Now, this is keeping this parallel, because this is very anteriorly placed. I keep this parallel to this and make an entry for the next screw. You have time till that time.
So we want to see the lag screw.
Okay, I'll use the lag screw. Good. I take an incision here.
Dr. Sunit Hazra's patient, so he wants you use the lag screw.
Yes. See this. First I apply and fix it here. Okay, once it is fixed, now I can push the sleeve. Shoot. Dikhai over there. Can you see that? The sleeve is out. निकल रहा है बाहर अंदर जाने का. Shoot. Okay. Shoot. एक मॉप दीजिए मेरे हाथ को. Shoot. So by tightening this turnbuckle nut, your sleeve will go and touch the inferior. There is small peg that will fix it to the lateral cortex. Unfortunately, this has slipped out. I will reduce it. Yeah. Leave, sir. Otherwise, you can operate. I will go away. Shoot. If I am turning it little more, because I am not inside the soft tissue, it is breaking, so I will leave it at this stage. Guide wire. Shoot. Push the nail little down. Guide wire. I have 4 people, all of them looking towards me only. Shoot. और भी नीचे दबाइए. Shoot. Yeah, this is okay. Shoot. Okay, lateral view. You can see that the guide wire which is in the inferior part is going in the inferior part of the head.
Yes.
That is the angle which I am aiming. By chance, if it is going in the center, I try to get it inferior, either by little slightly bending of the guide wire, which I normally don't like to do, otherwise getting the reduction properly. You can see that it's in the center of the head,
Yes.
slightly posterior.
Right.
You can take little oblique and show. Shoot. Okay, shoot. Shoot. No, it's not possible for me to. और थोड़े oblique कर दो. Shoot. Anyway, it's okay. AP. That is the reason why I said I always fix the anterior K-wire first, lag screw, उसके ऊपर tap, shoot, measurement, AP shoot. It is exactly in the subchondral area.
Yes.
So
and inferior also.
It's 95 here. So now I am using the lateral cortex breaker. This only enters up to the nail. It cannot go beyond this. So I will show it here. And there is a stopper here also. It only breaks the lateral cortex, shoot and save. It cannot go anything further. Okay?
Okay.
हाँ नहीं ठीक है 90 दे दो चलेगा because I want the back end of the screw outside. As you can see that the और एक बार shoot करके दिखाओ. See the sleeve is not touching. There is a 5 millimeter gap between the.
So do we have a head on this lag screw?
No, we don't have a head on the lag screw. That's why I am trying to keep the lag screw out by 5 millimeter. So the measurement is about 85, but I am intentionally taking 90. Shoot. Shoot. You can see that 90 is going properly. Shoot.
And then, sir, how would you planning to compress the fracture?
I am by pushing the sleeve out. That's what I am telling. This nail is I am demonstrating for the purpose of demonstrating. It's not an ideal case. This is a undisplaced fracture. That's why it's okay. I cannot compress any fracture with a headless screw.
Sir, are you what is the message to the delegate to use?
Message to the delegate is if you are doing a PFN A2 नहीं drill की जरूरत नहीं अभी screw directly. Yes, if you are using a system apart from that, it is only good for a stable fracture like this. That's all.
And the head screw is good for all.
90. Yes.
A screw with a head is good for all.
Yes, screw head is good for all. As you can see that this surgery I have not done for the last 2 years. I am only doing during demonstrations. Because the company wants, because you people ask them to do it. That's why I am telling.
Sir, I am your follower.
Yeah. So what I am telling is, you should only use the regular PFN. But people will ask, what is the literature?
Yes.
Unfortunately, this PFN is not available either in Europe or in America. It's only available in India. Shoot. The reason is, the nail is patented initially by Smith & Nephew and initially by Synthes, and in 2006 the Smith & Nephew went to the American court. I know the exact date, 29th of September 2006. They went to the court, shoot, and exactly on 29 days, 29th of October, the court has given the verdict saying that PFN is patented by Smith & Nephew, the word. Nobody can use this apart from them. Okay. So Synthes came, since they wanted to have a market, they came out with another nail, that is PFN-A2, PFN-A. Then in 2013 they came out with PFN-A2. Now I am compressing the fracture. See what has happened. You have to, there are slots here in the screw. Give me a screw. You have to keep it at 90 degree. There are 4 slots here. Okay. Yeah. Either you can keep here or keep here or keep here. 90 degree you have to rotate. Either this has to be horizontal or it has to be vertical. So I kept it horizontal. I got a good subchondral purchase shoot. I don't want to go anything further now. Now to compress the fracture, I can push the sleeve in. See the system here. This will push the sleeve along with the outer cortex inside. Fracture will get compacted. Shoot. So by compressing this, I am compressing the fracture whatever it requires, and I am retaining that compression by putting a top screw from the top. Shoot.
So you are keeping it in a static mode?
Yes, yes. Because this is a stable fracture, I compress and put it in a static mode. See, I cannot further compress it. Shoot.
So do you release the traction?
Yes, it has to be released. Yes. Adak karo aur thoda ho sakta hai कि then I have to put the top screw. Give me the top screw. I have released the traction already once. Actually, the only thing I have not done is I should remove the K wires also.
Yes, yes.
This I have forgotten. I will remove the K wire and again tighten it. Yes, K wire nikal do. I will tighten few more millimeter after removing the K wire. So leg end traction has been removed, released. The K wires are released. Let it be eccentric, don't worry. Now we are anywhere removing it. Okay. Okay. Now I removed the K wire also. Again I will tighten it again. You can see that I can tighten by few more threads. Shoot. Beautifully now it is compressed. Can you see that picture?
Yes, yes.
Shoot. Yeah. Now top screw. Top screw. Okay. Shoot. So I am putting the top screw in the static mode only. Why I am to show this is, even after tightening the top screw, I want to say that this compression whatever I achieved will be lost mop to some extent. Is there anything other instrument to hold this and tighten? I have got actually a proper screwdriver. Okay. Anyway, I have done good compression here. Leave sister. Shoot. Okay. Now I will take out the this screwdriver. Your hand, you should look. You are orthopedic surgeon, no? You should look. The delegate should see, not you. Take that out. I am taking out the screwdriver, and I am taking out the screw and also the guide wire. Yes, screwdriver. Yeah, give. Yes, full. Before doing the distal locking, always check that your alignment of the limb. So give the distal locking. Now you can see it is slightly internally rotated. Though I have passed the neck screw, I keep it properly in external rotation. Before I do the distal locking, I will ask the assistant to hold it properly in this position. आप इधर आ जाए बस, ठीक है, आप की जरूरत नहीं. I am keeping it about 15 to 20 degree externally rotated. As the patient is already tilted, I have already internally rotated the body by about 15 degrees. and now I am keeping the leg externally rotated by about 20 degree, means patient's limb is externally rotated by about 35 degree, that is the normal sleeve. I always do the dynamic distal locking. थोड़ा नीचे लाइए. Distal locking sleeve. 24. I want the 18 millimeter, 18 centimeter. So again, see, this is a mistake. 240 centimeter, 24 centimeter jig has been given to me.
Sir, there is a question, why you always prefer the dynamic locking?
See, all nails require certain amount of collapse. It's 1 or 2 millimeter. If you do the static locking, that collapse will not happen. So, if there is a dynamic option available, I will always prefer to put a dynamic hole.
Even in severely comminuted
Yes.
fractures?
How much this hole can allow collapse, you tell me, 5 millimeter, 6 millimeter. But that micro motion which happens will lead to early good callus formation.
Okay.
So, take the gloves. So they are opening the another box to get the 18 centimeter guide, the jig. Hopefully it is present. Yes. The nail you are given is 18 centimeter, na? Or nail you are given is 20. Anyway, I will check again with the. Now I got a 18 centimeter jig. Shoot. Sleeve here. Knife, sleeve. I'll just check it before shoot. Yeah, it's dynamic locking. Hold it like this, horizontal. Knife. Hammer. Shoot. Okay, no problem. Okay, drill. And keep ready 38 millimeters bolt, locking bolt. See, by holding the jig parallel, I am sure of the angle at which the foot is there, and also I am not in an awkward position to drill. Shoot. Okay. Take sister. Take. Drill sleeve. This is a 38 millimeter screw bolt I am using. I want the bolt to be out on either side by 2 millimeter. I don't want the head here to touch here because it's a threaded screw. Shoot. 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 I want good purchase of the threaded screw on either side. Shoot. Perfect. Shoot and save. Now I'll remove the jig. ऊपर से निकलने का. आप किसी का कैमरा है तो है? Now I'll remove the conical bolt. Shoot. आप ऐसा कीजिए, adduct and interrotation. Shoot. हाँ? नेल नहीं खुल रहा है, ठीक है, गिव. Okay, shoot. Now you can see that my screw is outside in the lateral cortex. I wish I had little another 2-3 millimeter inside. That's fine, perfect. Then you can see the good valgus. The screw is inferior in the head and neck in AP. The nail is slightly out at the entry side, lateral picture. The trochanter is posterior, that's why it appears it is medial. But because of the entry, there was a fracture of the trochanter which has gone posteriorly. Shoot. There is a good anterior cortical reduction. You can see the trochanter. Thoda table up कीजिए. Thoda table up. Slightly up. Because the trochanter, there is a fracture, it has slightly gone up. It appears that in the AP picture, my entry has become lateral to the trochanter, but it is not due to that. So my entry is also good. Then slightly come distally. Shoot. The nail is properly in the center of the distal canal. There is no anterior impingement. The distal locking is fine. Whatever the 10 points I have talked, everything is fine. This is a gun drilled nail I have used.
Thank you.
Yes.
Excellent, sir.
Thank you very much.
Thank you, sir.
Yes. Anybody has camera, we can take a group picture and I can share it. You can stop sharing the screen from here. I will come there and answer any questions. Come.
Yes, sir. Okay.
You have to send it to me. Come. 1236. He is born on 12th March. Anesthetist?
Yeah. Thank you, sir. A great team, great surgery. Everyone is very happy.
Thank
you. We should also thank our anesthetist, Dr. Suvanjan is there.
Thank you.
And the whole team of staff, sisters and OT brothers.
You can put,
thank you all.
Required. So if you want, you can put the top screw also. Here it is not required. But anyway, since the assistant has given, I am inserting the top screw also. Thank you. You have to send it to me. You have my number? निकाल दो, कपड़े निकाल दो मेरा. Thank you, sir. Thank you, anesthetist. Thank you, Shiva. 98224 024.
Happy Teachers Day to all my teachers present here. So she was a 76-year-old female who suffered a domestic fall, presented 3 days after her fall. So this was a rather innocuous looking preoperative X-ray. The plan was a close reduction of the PFN and the operative and post-operative period was uneventful, discharged on POD3, on-bed exercises and high support. So this was the post-operative X-ray. I am sorry the lateral view is not available. Was sent to me by one of my very close seniors. So at 6-week follow-up we see this. So this is at 3 months follow-up. And this was at 5 months follow-up. So eventually it was salvaged.
lateral view is not available. That is the problem. Sir, possibly I'm not sure of the lateral view, so I think maybe there was a deficient anteromedial cortex. There was some sort of comminution there, possibly from what it looks like, and maybe I'm not sure. Possibly the inferior screw seems a little large. It's not compressing. It's not compressed, and I had asked the history, sir, from the treating surgeon. He said the patient said there was no history of premature weight bearing also. So they probably will deny, but it might be some sort of premature weight bearing as well, because the way the surgery is to cut out. I I know, sir, but this not probably. Right, right.
Very good morning, everyone. Happy Teachers' Day to all respected sir, my dear fellows. I'm presenting basically a case-based learning and putting a question answer. And if we had any difference of opinion, please suggest. So this is the case. Presenting the case of 80-year-old female who had a history of slip and fall, sustained injury to the left hip. As you can see, this is the emergency room X-ray, the pelvis with both hip and AP and the lateral view. It is a simple intertrochanteric fracture with the LT fragment involving. So as per the Evans classification, there is an intact posteromedial cortex. It's an Evans stable. As per AO, it's A1, A2.1. Yes, sir. On the lateral view. Okay. Okay. So what would be the treatment of choice? A2. We proceeded with the DHS. So clear cut problem. And please comment on the reduction implant hip screw in neck and head position. Yeah, the next. Yeah. Yeah. 135%. Yeah. The same closer look of the lateral view. Please come. Yeah. The fracture reduction, the condition of the posterior medial cortex, and the implant. Which one? Yeah. This is the this is the follow-up X-ray after 1 month. Now what? I look at the reduction. What is it maintaining the reduction, and is it a stable fixation or not? Or is there anything like implant failure? Yeah, you can see the yeah. We took so this is the closer look of the same X-ray in the AP and the lateral, the post follow-up X-ray at the 1 month. So why did it happen? The screw displacement and the collapse at the fracture site. What's your theory? Yeah, medial one. Yeah. In this case, we consider the posteromedial calcar fixation. And regarding the collapse at the fracture site, so we came out with the theory like it's already a 80-year-old female. There is a osteopenia. So that is the reason for losing the purchase of the screw in the femoral head. We expecting this. Okay. Yeah. Yes. So next question is how to prevent that. Any suggestions? We are expecting these two options. First is the cemented screw placement in case of the osteopenia, and the second is the please pre-op the DEXA scan if possible or the seam intact as per the X-ray. So future consequences. How to? What? Okay.
the profile of the patient. She's a 30-year-old lady, quite obese, again a homemaker, had a history of RTA leading to a subtrochanteric fracture. There were no neurovascular dissection. The first fixation which was done. So we have been listening many commandments as pointed out by sir, how to fix these kind of fractures, either intertrochanteric or this kind of complicated subtrochanteric fractures. So can you please point out the mistakes which was there in this particular fixation? Yes, sir. adapt the fragment and then make an entry point. So this is the immediate post-op. This is again 8 weeks post-op. Still there are no external signs of infection. So moving on to the next side, this was 3 months post-op. So anyone please suggest what should you do next?
Yes, yes. Elezra is for my enemy, not for yes, absolutely.
So yes, this was the thing done. As sir pointed out, debridement was done, and the implant was removed, and a KNL with antibiotic cement was applied.
Yeah. But lateral fracture is also tied.
Next, moving on. This is 4.5 months post-trauma and 6 weeks post
with infection.
second surgery, the debridement surgery.
And also I think stimulant graft have been put. No. I think there I can imagine some beads there.
What about the neck of the tumor?
Assuming that the inflammatory markers are down by now and there is no discharge, so what should we do next?
How long the KNL?
So 6 weeks post repair.
This is request fixation. Again now, once the infection is now controlled, I am going to do the PFN with augmentation plate and bone grafting. That's one option. Other option is I will excise the ends again and I will do a transportation. I use the LRS system, unilateral fixator and lengthen the neck. But my preference is get the union pass by fixation, nailing and augmentation plate. The shortening I will take care at a later date. I can do the lengthening of the tibia at a later date.
Okay, so this was the third surgery which has been done. Again,
failed. Yeah. No
all
fixation.
of you can point out the mistakes which are present in here.
Those who will point out the mistakes have to proceed. Yeah.
Then I will not contact them.
Cannot be allowed to the war field.
Yes. Arnav.
So this is
Okay.
the third suppose after the debridement the infection subsides, how would you like to fix it?
May or may not be the problem. Depends on what the end of the
Anyone wants to use the locking plate? Yes.
A single locking plate is not going to have any help because there is a segment where it is weak point, it will break. So double plate is okay.
So we have three options right now. We have a incremental implant, a DCS or a locking plate. Of course after a debridement. Now as this is a highly discharging and highly infected case, so proper debridement is very much necessary. This is the fourth surgery which was done. Implant was removed, again debrided thoroughly. This debrided thoroughly term is quite commonly used but very rarely done properly in the OT. So and lastly we had given antibiotic semen.
Now the patient is discharged pain free, he doesn't want any surgery. He's fed up.
So we had done CT scans to assess the quality of the bone which was still left. So these cuts also you can see. So moving on to what we had done, a DCS was done, a very long DCS plate. So this is the fifth surgery, hoping that the patient doesn't require any more surgery further. No, ICBT graft.
Yeah. See, he is showing here means it has united, that is different. But the medially, that bone graft is still inadequate. I will rather put a small anterior plate where just 2 screw above and 2 screw below, that will share the mechanical problems. Yeah. Okay.
And the bone was also quite osteoporotic till now.
Yeah, because of disuse osteoporosis, definitely it will.
This is 2 months after the last surgery. 8 months after the last surgery. 21 months post trauma.
YouTube पे क्वेश्चन में Yes, sir. Just I will ask those questions. Yeah. बहुत क्वेश्चन है राजीव. 9 questions आया. एक करके पूछो. The first question on YouTube is, sir, indication of PFN over DHS.
Indication of PFN over DHS. Friends, intramedullary nail is always better biomechanically. It's a load-bearing implant, unlike a plate which is load-sharing implant. So, intramedullary implant is definitely better. So, I feel that there is nothing better than that. Okay.
Next question is advantage of PFN in stable trochanteric fracture. So,
see, even in a A1 and A2 type of stable fractures, almost 20 to 30% of the lateral wall, if it is precarious, breaks while we are doing surgery and becomes an unstable A3 type of fractures. So for a A3 type of fracture, PFN is the treatment of choice. Why don't you use PFN instead of trying to put a DHS, then break the lateral cortex, then you switch over to PFN? That's one thing. And other thing I can tell is, if you are new to drive a car, where do you learn driving? On a busy highway or a open field where there is nobody? So start doing PFN in a simple trochanteric fracture first, learn the technique first, and then you graduate on to unstable fracture. That's my way of thinking.
third question is a tip and tricks regarding proximal femur fracture. I think already you have told about 10 tip and tricks for proximal femur fracture reduction. Yes, already you have told in your previous lecture. So lateral approach to old trochanteric fracture with PFN. Yes. I think it's lateral position there he is asking.
Lateral position I use it for subtrochanteric fractures. Yeah. I not use it for intertrochanteric fractures or intertrochanteric with subtrochanteric fracture. Yes, lateral position is a very good position. If the trochanter and the little up to the lesser trochanter proximal femur is intact, it's a very good position. Very easy to operate. It saves a lot of time.
So now the next question is related to that tricks for reduction of subtrochanteric fractures. The lateral positions, sir, how do you reduce those subtrochanteric fractures?
Subtrochanteric fracture I will be giving a talk. So.
And what is the exact entry site to prevent varus deformity?
Exact entry site to prevent varus deformity from the piriformis or medial to the base of the trochanter. There is nothing else. That's only one.
And what is your weight bearing protocol?
I always allow weight bearing in the immediate post-operative period. I give walker to the patient, ask them to walk. It depends on their pain free and stability of the fracture. They either put 10 kg weight or 50 kg weight. I will not withhold them to put the weight. Our fixation has to be proper. My screw, like today, has to be in the inferior part of the head. My head and neck should be valgus. That will hasten the union if you allow weight bearing. Because the fracture hematoma have BMP, bone morphologic proteins in that. By putting the weight, they will be stimulated to get converted earlier into callus rather than delaying it. And there is no role for non-weight bearing. If the patient is jumping like this, the weight itself is distracting the fracture site. So always allow, even in badly communicated fracture, at least 10% of the body weight to be put. There is no role for non-weight bearing in a nailing. If they put non-weight bearing, the fracture gets distracted due to the weight of the limb itself. So don't walk the patient to walk with the leg up. No, at least toe touch. Yes. For any fracture, tibia, femur, subtrochanteric, everywhere.
And last question is role of doctor working in periphery prior to shifting to orthopedic center. I don't know what he wants to ask. I think regarding doctor if working in periphery, if you want to send.
Yeah, definitely. See, even if he's working in a periphery, there will be people from Kolkata to go and help them. So you involve your friend, ask them to come and do surgery, initial few surgeries. Then once you learn it, you start doing yourself.
Or transportation of those patients.
There's nothing much I can add.
All right, yeah. So.
Okay, I have two things to talk. One is why PFN, regular PFN is useful. Last week, Dr. Rajiv has heard this. Another one is reduction of subtrochanteric fracture. Which one I should take first? Reduction of subtrochanteric fracture. Reduction of subtrochanteric
I invite all of you for our IOA call at Goa. It's from 21st to 25th of December. It's the peak season in Goa, so I request to book early. Dr. Rajiv Raman has already booked his ticket, so ask him and join him, because there is only one direct flight from Kolkata to Goa. So it will get filled with Rajiv Raman and his friends very quickly. So coming to the subtrochanteric fracture, there is high subtrochanteric fracture where the fracture is at the level of lesser trochanter, just above the level of trochanter, which I operate on an orthopedic table, and fracture extending below, where I operate on a simple table. If there is intertrochanteric with subtrochanteric fracture, I operate them again on an orthopedic table. The commonest problem seen with a subtrochanteric fracture is the nail goes medially in a wide proximal medullary canal, leading to varus. The same thing has happened there also. You should be parallel to the lateral cortex. That is very, very important. You should go through the green line, avoiding the red line. If you go through the red line, always varus happens. You can imagine the earlier case, that was a culprit in that case. So it's easy to pass medially. Even today also you could see that my guide wire was going medially. What I did, once I inserted a thicker instrument, I removed the guide wire and pushed the reamer and went parallel to the lateral cortex. So going parallel to the lateral cortex is very, very important in these fractures. That's the crux of the treatment. Coming to the entry side, there are various entries: tip, lateral, piriformis fossa. Piriformis fossa is actually misnomer, because piriformis fossa is not in the exactly in the center; it is slightly posterior. So what we have to do is slightly anterior to that, medial to the base of the trochanter, but exactly in the center. What I was trying to show today. So see, such a beautifully reduced subtrochanteric fracture. When you insert the owl, also nothing has happened. But when you insert the nail, see, here it is reduced. As soon as the nail is inserted, the proximal fragment goes into varus, because the nail is going medially. This has to be avoided. There is very high percent, almost 40% of non-union and implant cut through because of this varus, which you have seen just now in the last case. That was a beautiful example for this. See, if you put a nail from the tip of the trochanter, it's not going to enter into the medullary canal. When you try to enter into the medullary canal, what happens is the fracture goes into varus. Why don't you take the entry from the piriformis fossa in line with the medullary canal and go it smoothly without causing the varus? This was again a demonstration case done at Sancheti Hospital. You can see the entry from medial to the tip of the trochanter. I am able to pass a 11 millimeter nail. This is a very thin bone actually, 11 millimeter nail without causing any varus at the fracture site, only because of the entry, which was very, very important. A similar case, 10 years back somebody has operated, see the entry, that from the tip of the trochanter, and the fracture has gone into varus. So much of varus you can see, and it is going 10 years the nail could sustain the load. Probably this is a Yogeshwar implants gun drill nail, that's why it has sustained for 10 years. But it has broken at one day or the other. What I did, I used a Steinmann pin, put it lateral to the entry. See the entry, I am going from the neck on the right side, you see, and I pass the nail. The nail should not go to the earlier track, so I have put a blocking screw there, polar screw, and that has done the job. And see the valgus. So getting the valgus, and I also added a plate as well as bone graft. This is what I was telling, augmentation plate with bone grafting. Within 4 months, the fracture healed and the patient started walking without any problem. And then it runs, I'm not sure, let me check. Okay. Anyway, this is patient moving the leg. Always I use a Steinmann pin in the proximal fragment to have a control if the small fragment is small. This is a 75-year-old lady. There, if I put the reamer directly, many a time there will be unsuspected crack intertrochanteric fracture. The greater trochanter breaks. So I always fix that with a K-wire. That will also give me direction of the neck for passing the neck screw subsequently. Two things it does. So then you see the entry. See my, I'm adapting it, getting a valgus, making an entry medial over the neck, then enlarging that with a 10 millimeter owl. This what I'm very, very happy with this curved owl. I'm going parallel to the lateral cortex. You see, this is where the space is needed for the nail. Even while I am passing the reamer also, same, the nail remains there. The bone which I have not removed here will act as the polar. The nail cannot go because it is blocking for the nail to go. So good valgus I have got. See the position of the neck screw, distal dynamic locking. This is the final picture on table. This was so. This is immediate postoperative picture in the same patient. So there is no varus. Good valgus. See the position of the neck screw. See the subchondral placement. Calcaid is less. Everything whatever I have been talking is there. So it's going to give you. This is a YouTube video, subtrochanteric fracture I operated at Akola during a workshop. You can see the nail is parallel to the lateral cortex. I am not going medially, there is no valgus at all. That is the crux of the treatment. Even if there is slight opening of the fragment medially, don't worry, get good valgus. So this is available on the YouTube, a 49 minutes video is available. If the low subtrochanteric fracture is there, you have to go parallel to the lateral cortex. And if the proximal fragment is intact, I always prefer to operate on a lateral position, especially hefty patients, more than 100 kgs, ladies with big fat. This is very good way. Siam for AP, Siam for lateral, cross table lateral. You can also abduct the limb and take the, just keep the Siam like this, abduct the limb. You can get the lateral of the hip also. But you can take the cross table lateral also. And the advantage of this position is, on the left you can see the Siam in the AP, on the right you can see Siam in the lateral view or cross table lateral. Both the places I am operating, I am putting the instrument. Today I had put the guide pin. When the Siam came, it pushed it out. I had to take it out, take the Siam again in AP and put the guide pin again back. So that problem is not there. I can properly position my guide pin wherever I want, without the Siam coming in my way. That is a very, very advantageous. There will be two hips. Once you put a guide wire or K-wire like that, you will know which hip you are operating. So you get used to that very easily. So as I said, always, even in an intact proximal bone, I put an anti-version guide wire that will give me the direction of the neck. Parallel to that, I can keep the jig to do the nailing. So see the entry, where I am taking. Parallel to the lateral cortex in AP, parallel to the anterior cortex in lateral view. Enlarging. Before this, never enlarge, never use the owl. If you open the middle canal with the owl, your guide wire will go there only. Always put your guide wire first. Get it confirmed. Take it out if you are not happy. Again reinsert it. Once your position is correct, then only put the reamer and then ream and do the nailing. As I can see, the anti-version guide wire gives me the direction of the neck. My guide wires are being blocked by the nail. By rotating the jig, I can slightly see the thing. This is final on-table picture. As said earlier, dynamic distal locking. There is no abduction deformity on the left. There is no flexion deformity on the right. So this is the advantage of this position. So very easy to operate. This is immediate postoperative X-ray. This is sometime later. This is at the end of the union in this patient. The last part, intertrochanteric with subtrochanteric fracture. So what I normally do is, I always fix the intertrochanteric fracture with a K-wire or a screw. I'll convert that into a pure subtrochanteric fracture. See, the lateral wall is sagging in this case. The lateral wall is sagging. So what I did, I passed the K-wire, lifted it up. The neck I have pushed it down. The neck was above. So with a Steinman pin, I pushed it down, got the alignment first. Once I got the alignment, I fixed that with K-wire. Then what I did, I passed a guide wire, a 6.5 millimeter cannulated cancellous screw guide wire I passed. And then this is also very anteriorly placed. You can see that they are very anteriorly placed, so that it is not going to come in the way of my neck screw. So I passed a screw. Now it is, you can see that screw which is very anteriorly placed. I have placed for the nail as well as the neck screw. Now I am using the Steinman pin and adducting and making an entry. I have a control. This is a pure subtrochanteric fracture now. I am making a fresh entry. Then I am making the entry with the reamer, passing the nail and doing the distal locking. This reduction I am little not happy today, but today if the same patient comes to me, I will put an insert clutch wire also, but at that time I accepted this, not much of displacement, and it went on to do well. This is I did with one of my friends. As I said earlier, if there is a banana fragment, I always try to fix that with a encerclage wire with a small incision. I will show that. This is again a demonstration case I did during Vairok in 2000, I don't know exact, 2016 Vairok. I did with Dr. Atul Patil at Bombay KM Hospital. So this is wiring I did pass before doing the ZNN in that case. If there is a long oblique spiral fracture, I always try to get the reduction first with encerclage wire. With a small incision, you can put the wire. With a small incision, I have done the reduction. See the number of threads. This is all the incision I have taken, and I'll show the small video also. And I'm able to do the wiring first. There are costly instruments available, but JBCH can purchase them. But I am working in a small setup. I use made in India instruments and implants. So this costs about 7,000 to 10,000 rupees from JJ Surgical. A beautiful instrument. So on the left it costs about 5 lakh rupees. The same instrument costs less than 10,000 rupees. Atmanirbhar. If it is good, made in India, use it. If it is bad, don't use it. I don't want to say that use all Indian. No. Good Indian things you should promote. So that's my theme for this year. Atmanirbhar orthopedics. Indian at heart, global in competence. Your skill should be next to none. But you should have empathy for your own patient. Atmanirbhar. You should use your own locally available things and do the surgery to your best. Another elderly patient, intertrochanteric with subtrochanteric fracture. Again, what I have done is same. I have passed the K-wire first, then fix the fracture, then I am passing the Steinmann pin and adducting the fracture, then I am doing the subtrochanteric wiring. Hopefully this runs. No. So what I did was the wiring of the subtrochanteric fracture. Yes. I am taking a video. I have taken an incision, pushing the artery portal at the linea aspera and opening the soft tissue. The wire passer. First I will pass the inferior one because passing the inferior one is always difficult, and then I will pass the superior one. Now I will hold both of them together and to pass the wire. Now we are passing the wire. You can see. Now I inserted a 9 millimeter nail and over that I am tightening. Yes. I am taking a video without any problem. I'll go back to the first slide again. You can take two wires. Nowadays I use cable. I will show that also. This is the final picture on table. You can see that I fixed the where I passed the K-wire to fix the intertrochanteric fracture. I replaced that with a screw at the end of the surgery, and that fixes the intertrochanteric fracture, distal dynamic locking. This is immediate picture on table. You can see that my screws are not coming in the way of the neck screw or the nail. That is very, very important. Small incision through which I have passed both the neck screw as well as the encerclage wire. So another 92-year-old lady. Everybody will think of replacing first. Why we want to fail in such an elderly osteoporotic patient? You can see 92-year-old lady. I operated with my friend Adarsh Mehta. Again, you can see on table reduction, fixing the fracture with the K-wire first on the right side, taking the entry in the center, using the out to get the alignment guide wire parallel to the lateral cortex. I was not happy with this abduction. Because it's a long oblique fracture, I again opened up with a small incision the linea aspera, then passed the wire passer, got the fragment together, then I have done the nailing in this patient. How I prepare a nail? What I normally do is I
use both the wires together and hold on one side with the help of a chuck. Handle on one side, and on the other side I fix a power dimmer. Now what I am going to, with good tension given from both sides, they uniformly become a good, and hold on one side with the help of a chuck. You can form this cable on your own by passing 2-3 wires together, and you can use them. So with the cable I have formed with 4 wires. Delete. You had the, we wanted how many wires you want to pass. Why we want to pass cable? Why not single wire? See, on the left you can see that if I am using a thicker wire, so much of area there is pressure is happening, whereas you use a cable, the area on which the blood circulation is hampered is very, very less. The area on which it presses is very, very less. So always try to use a cable wherever it is possible. Here you can see I have used a cable. So yes, cable 2 wires up to 4 wires that can pass. So I have passed through that only, and I am holding it together in there. So this is the immediate post-operative picture. On the table you can see beautiful reduction for such a bad patient. Through this incision I have passed the neck screw as well as the cable. Pre-operative on the left side, post-operative on the right side. And if you see all the factors whatever I have told, you can see that everything is there. All the 10 factors are good. It is going to unite. Good subchondral fixation, good valgus, the nail outside at the entry side, well compressed fracture side, medial alignment proper, distal dynamic locking. So you find out, you tell me what is wrong in this patient. So this is what you have to analyze. If everything you have done, it's going to unite without any problem. Another intertrochanteric greater tuberosity avals, medial butterfly fragment or the banana fragment, lateral wall thick. So what I did was, first I fixed the banana fragment with a wire, then I fixed the greater trochanter with a wire, then I fixed the intertrochanteric fracture, the lateral wall with a screw, then I made an entry, you can see, medial to the base, then I passed the guide wire, then I have passing the nail with using the finger, then I have passed the nail. You can see that this fragment is going out because I have used only one wire, but afterwards I used another wire to fix it, so that abduction also has been reduced. This is the final picture on table. So everything has been tackled. Greater trochanter has been tackled, the wiring has been done to the greater trochanter, screw is fixed to the lateral wall, medial fragment has been fixed with the, so you have to think about the fracture, accordingly you have to take the action. Another fracture, huge lateral fragment. So this is on table. What I did was I planned to do encerclage wire. I passed one encerclage wire. Then I have used a Steinman pin to adduct the fragment. Then I am taking an entry. This is an anti-version guide wire. This gives me direction of the guide neck. As I said, every fracture I put it, so that after you pass the nail or after there is jig, sometime you will not be able to see the neck properly. This saves lot of time. So then you can see the entry, where the entry is much more medial to the base of the trochanter, almost from the piriformis fossa. Then I am opening, I am using the finger to get the reduction. This is the finger instrument I use regularly in subtrochanteric fracture. The fragment which are moving out, I am trying to get them back with a cable here. Then I am reaming. Then I have passed the nail and done the proximal locking. There is a positive cortical support you can see in the neck in the lateral view. That is very, very important, because in the AP it looks like a negative cortical support. If you see the AP of the neck, it looks like a negative, but it is definitely positive cortical support. This is the advantage. See the anti-version guide wire, parallel to that I am able to pass the neck screw. So neck screw is being passed. You can see that with single wire, a large fragment will have a seesaw effect. Once you compress on one side, the other side starts lifting up. So put another wire. Only 2 wires were not sufficient, so I put third wire also. So 3 wires I have used, 1 wire and 2 cables I have used. So total 5 wires have been used. With a small incision I have done all these things. This is the lateral at the fracture side.
I didn't do the distal blocking. The reason was there was a bad infected wound on the lateral aspect of the thigh. This was a silencer burn wound, so I didn't want to go through that part. So, but patient did extremely well. 3 months post-operative. He came only once at 5 months, and subsequently he has not come to me. But whenever I call him on phone, he said that he is doing fine. He will come, but he has not come since 2009. So, if you do tackle everything, that will be fine. Nailing doesn't mean that accept mal reduction. You have to. There is definitely place for minimal open reduction, proper open reduction, planned open reduction, not unplanned. So you can open and put the things back in position and get a better reduction. That's very, very important. We have beautiful instruments which can help you in mini open close reductions, or even you can use a clamp, hold the proximal fragment and do a proper nailing instead of doing a wrong nailing. So this is about the subtrochanteric fracture. If you have anything, I will answer at this stage. Otherwise, I'll just finish up my last part. Why? Because there was question again for a stable fracture. Why I prefer regular PFN? Why I don't prefer the regular PFN? Newer implant. So, see, any stable fracture can be treated with either DHS or a nail. That's not an issue. Or any type of intramedullary nail. Like today's fracture, that's the reason why I used PFN, whatever the hybrid ZN type of nail of this company. The reason is it's a stable fracture. Even if I put 2 screws, it also is going to give 2 pieces. These are the cases I can learn the technique of doing a nailing properly. Then I can use it in other cases if required. But for an unstable fracture, I always prefer the PFN. So let's compare. As I said earlier, for a stable fracture also I always fix the fracture, then only I do a PFN. This is a PFN A2 I have done. A stable fracture, this video is there on the YouTube. I have done a PFN A2. It has united without any problem.
This is the 65-year lady operated 1 month back with PFN A2 on the left side. She has come today for follow-up, walking comfortably with a stick on the opposite side.
Fracture itself was stable.
This is the 65-year lady operated 1 month back.
So at 2 months you can see beautifully the fracture has consolidated. At 4 months there is nothing more I can do. So probably I could have hammered little more inside. That's the only thing there is short there. Because that is a learning experience. This is one of my first PFN A2 I have done. For the last 15 years, many newer nails have come. PFN A2, Trigen, Zimmer nail. Everybody thinks that anything new comes in the market is better than the earlier. Okay? That is a common feeling. But not necessary. There is commerce involved with that which you and I may not be knowing. There are so many newer nails in the market like Gamma nail, PFN, PFN A2, Trigen, ZN and Halifax. Is there a gold standard? For a surface implant, we have DHS as the gold standard. Similarly, do we have a gold standard amongst all of them? Implant of choice for intramedullary, my choice as I said is intramedullary hip case 2-screw system with PFN. Because 2 screw is better than 1. It's proved beyond doubt. Study has been done with Gamma nail with PFN, 2-screw system. 1-screw system removes 40% of the bone, whereas 2-screw system removes only 30%, less than 30% of the bone. Cutout chances with the 2-screw system is less. There is enough of literature available before 2000. All the literature saying that 2-screw systems are better. Our own Indian literature, Amit Rastogi from Varanasi has done, where PFN only 1 out of 9 failed, whereas Gamma nail 5 out of 9 failed. All the 8 sustained a load of 50,000 cycles in PFN, but in Gamma none of them sustained cycle of even 20,000 cycles. If you go through the whole article, probably if you had 50,000 cycles for Gamma also, then everything would have failed. So 2 is always better than 1. when two is always better than one, why we have got single screw system becoming more popular? The reason lies with you and me, because I and you think that one screw system is easy to pass, because it's very difficult to pass two guidelines properly, two screws properly. So to save time during surgery, to have less headache for us, we prefer to use single screw system. And these marketing people are advantageously using our psychology to their advantage. So we find it difficult to pass two screws. Market blames it beautifully. The two screw system has a problem of Z effect. That's why newer nails like PFN A2, Trigen and Halifax nails are coming into the market. But the most important, which none of you may be aware of, patent issues. PFN with two screw system is patented by Civic and Navio. Nobody can manufacture. People ask me, Shiva Shankar, you are the only person you are talking about PFN is better than other nails. Why? There is very evidence. When the nail itself is not available for European and Americans, how they can use and produce the paper, you tell me? I want you people here, professors here, to give dissertation to your students and publish the paper. I am in a private practice. I don't have a large volume of work to produce a paper. So it's you people who are here, Rajiv, you people sitting in the hall here, Sumit, Arnab, other people, you have to give thesis to your students, get the papers published and prove that two is better than one. The patent issue is the one which has killed the whole market. That's why two screw system is out from the Western world. It's only available because we don't have the patent issues. Why PFN A2 is not good? It only compresses 5 mm or 7 mm depending upon the company you use. And they say that it compresses the fracture beautifully and there is less bone removed. But PFN when regular PFN A came in the market, there was disengagement problem, sliding out, all the problem were there. And the penetration was very high, especially with PFN normal contact, penetration into the joint was high. So they published saying that for PFN A, you have to keep, not subcondally, you have to keep 10 mm away. We all know that good purchase for a screw is in the subcondral bone, and they themselves say that you keep it 10 mm away. We all know bump hardness, keep apex distance, it has to be as subcondral as possible. If we go away, what to fix it with screw? So, in a single screw system also, the nail will go inside or come out. If there was a second screw, then it would have been a Z effect. Because the second screw is not there, we not call it as a Z effect there, that's all. But Z effect happens in them also. So PFN A gave to PFN A2 to give little curvature and other thing. The PFN A2 came in the market. See, this is my own case. The lady who was walking, that lady's X-ray only. This patient, you can see the black one where it is opened up. And when I tightened it, see at the white, it is coming back. Fracture, this 55-year-old lady, the fracture did not want any collapse to happen. So, while I compressed it, it lost its purchase and came out. One of my friends sent me this X-ray. He has tightened too much, it will disengage. He was unable to compress on table. Final result is the same patient, it walked out. This is my own case. I did the demonstration. Why the hell subtrochanteric fracture requires a compression, you tell me? I have to unlock the blade and hammer it. I have to compress it at the end of the surgery. It comes out. What has happened here? Without unlocking, I cannot pass it because the rotation happens only after unlocking. What is the fun of using a system in a subtrochanteric fracture like this? And they themselves have come out with a third variety of nail. The latest one, HFN, has come, where the nail rotates and goes inside. Earlier, they were telling that by this helical blade you can compress the fracture. Now, like a SP nail, it is only just rotating and going inside. This is the latest nail for the same company, which they are promoting now and they are not promoting the earlier two. means something wrong with the system. As I said earlier, compressing the fracture is very, very important. Fracture can be compressed only if there is a support from the lateral wall. If the support from the lateral wall is not there, you cannot compress a fracture. If the screw is lying not touching the bone, it is going to give trouble. You can see that. I can show n number of cases. Screw outside, the nail broke in due course of time. This is my own case I have shown. Screw. You can see how much it has gone out now. The recent X-ray. This is another case. Screw is outside. There is no subcondylar fixation. Walked out. Both of them had no surface. That's why I was telling the screw requires the support of the lateral wall, otherwise it comes out. That is the reason why, yeah, this is running now. So if there is a lateral wall combination, you all have heard my technique of fixing the nail against, see this patient is walking. Yeah. Elderly man, immediate post-operative period, I made them walk with the support. What weight they have to put every time. And these elderly people, you cannot say give 25% weight, 50% weight, not possible. They load whatever is possible, they will load. Even 100% they will load. At 10 weeks it is remaining safe. Since I have shown all these cases, I am just running through again another case after 4.5 years. This is again one more case at 1 month. You can see compressing the fracture also I have shown. So you had to compress alternatively the superior screw and the inferior screw. Here today also I use the technique of pushing the sleeve inside. This is the technique which we, this is what I wanted to tell. If there was a head for the screw, this compression I did not have to put the top screw, I could have left it there only. So this is very, very important. This also I have showed this patient. This patient also walking. When I went to operate that this next patient of the same again in Baramati I went, I did again this recently at 8th June. You can see the next screws are touching the nail and the patient is walking in the immediate post-operative period. This is 6 weeks X-ray the patient has sent to me. So I make them walk. This patient of 86 or 87 years old, he has all the various comorbidities. Ejection fraction was very, very less with a on-table death consent. I have done the surgery in this patient. Patient is very happy now, at least he has survived now 4-5 months. So the lateral wall, even Navin's plate or the Gonzalez plate also work as a support to the head. This patient, you can see had a comminuted fracture and so much of pieces. The lateral wall is broken, the posterior wall there is comminution, and this patient what I did was I used wiring as well as lateral wall. You see the neck screws are supported by the plate. The plate is acting as the lateral wall, and this is 6 week follow-up. This is recent follow-up on 27th of August. 23 months follow-up. You can see beautifully the fracture has consolidated. Patient is able to walk. See, patient is able to walk on the operated leg without support, but when he stands on the opposite side because of the varus and OA knee, he has to take the support of the limb. This is the same patient walking comfortably at 2 years. He has a fixed contracture of the elbow, so he was unable to hold the walker properly while I made them walk. So he was walking practically full weight bearing because of his earlier elbow injury. This another case, again this patient came to me in this position, and when I opened up there was an infection, but not very great infection, but there are some pus was seen. So I used the same technique, trochanteric buttress plate with wiring. I also used stimulant beads and paste I have inserted, and I have used the same technique in this patient. Unfortunately, due to lockdown, this patient has not come to follow up. Friends, there are so many nails in the market. Why? Everybody wants to have their share. Why the company has sponsored today's workshop? Because they want to have share of Kolkata market for them. So in the heat implant, the market is very, very high. Surgeons prefer IM implant despite there is no evidence. As per the AOS, there is no evidence to use in a stable fracture. So everyone has to have a share, and they are coming with newer implant. PFN is patented, including derotational screw. The word derotational screw is patented. Synthes came out first in the market with PFN in 1997, but Smith and Nephew had patented the word PFN in American law. So they went to the American court on 28th of September 2006, 27th of October 2006, within 1 month, the court gave the verdict saying that Synthes should withdraw the PFN from the whole market, from the whole world. They should withdraw the derotation screw. These are the details of the verdict. So PFN had no business now in the tip market. Will they keep quiet? 1 year, within 1 year, they came out with PFNA in 2007. They started blaming two-screw system, and they themselves came with a single screw system. And they had problem with PFNA, so they came out with PFNA too. Now they have come out in 2007 with PFN. All from same company. I am not telling about different companies. This is only because of the patent problem. So this patent issue. Now the patent of PFN is Smith and Nephew. If Smith and Nephew has got a PFN patent, why he is not selling PFN in the market? You all have a question. The reason is they are selling Gamma, Subhash Haldar. There is 1 million Gamma sold in Japan. 1 million Gamma nails sold in Japan. China and Japan, the commonest implant used at present is Gamma nail by Smith and Nephew. When they have got such a huge market for Gamma nail, they have their Trigen nail. People using Trigen nail left and left and Gamma nail. Why they will come with the third implant to compete with their own market? I am happy with Trigen nail, I am happy with Gamma nail. Why I should try in the PFN and I compete with my own tooth nails? You are understanding? That's why at present PFN is not available in Western world. When it is not available in Western world, how I can give evidence from the Western world? Nobody, apart from India, nobody has done PFN in the last 15 years, after 2006 or 2007. So use your judgment. It's not the implant, but the surgeon and the reduction which is behind the section outcome. Today's reduction was good, today it was a stable fracture. Any implant will do it, that's why you use it. If it was an unstable fracture, if there was a lateral wall fracture, I would have said, no, Tushar, I don't want to use it, I want the regular PFN. You understand? Thanks to Rajiv for supporting Tushar. So implant is just a tool to fix the fracture. PFN with two-screw system with neck screws having head can be considered as the gold standard because it can be used for any type of fracture. And after all, I am very happy. In 1999, I designed this Indian PFN along with Tushar. When I did this, I never thought that because the imported PFN is not having the head. The Synthes PFN is not having the head. I will go back to that slide again. The imported one, the Synthes one is not having the head. But to put a screwdriver, we are used to have a screw for a screw the head. That's why when I designed it for Tushar, I said let's have a head here. Which was, I did it unintentionally at that time, but now I know that though I have done it unintentionally, it is very useful. Thank you very much. Now I can answer any question, otherwise I am ready to take your leave. I do understand your question, but I have not done any study at present, but I have been using this technique and I have never failed so far, and it's for you people who are professors working in teaching institutions to do the study. Yes. will get the, as long as your neck, head and neck angle is valgus, you should not be worried. Yes. Yeah.
fractures with DCS. What should I do, sir? When I notice that it is lateral cortical broken. This is the immediate post-op, and after 2 weeks,
Hello. Hello. Is it audible in OT? This is a 3 months old fracture. That is why it is. 40 sound. Yeah, we are. Hello. We can't hear anything from the OT.
খুলে দে নাহলে পায়ে লাগলে আবার পাওয়ারটা খুলে দে ভাই এখানে রাখ
করতে অ্যাবডাকশনটা খোল একটু। ছাড়লে আবার এ হয়ে যাবে। না না, গ্যাপটা এই গ্যাপটা কমাচ্ছি একটু। এটা অ্যাবডাকশনটা খোল না। হ্যাঁ হ্যাঁ, একটু রাখবো, জাস্ট এটা একটু আছে, জাস্ট খুলেছিস। চল এবার নে লক কর। একটা ছবি দেখা দেখি। নর্মাল কেবার চাইছি, সামনে একটু টেম্পোরারি ফিক্স করে নেবো বলে, তারপরে আমি গাইড ওয়্যারটা দেবো। হ্যাঁ জানিয়ে দে এবার। হ্যাঁ জানিয়ে দে। ছবি দেখা দেখি। হ্যাঁ ঠিক আছে, মোটামুটি খারাপ না। না এখন ঢোকাস না, ফুটকে সরে যায়, ফ্র্যাকচারে দাঁড়া। দেখা চাবি খোল। ল্যাটারাল দেখবো একটু। কাটা আছে তো, কেবারটা কাটা আছে তো, মাথাটা কেটে দে, খোঁচা খাবো না হলে। ল্যাটারাল কর, বের কর বের কর বের কর নিয়ে। উঁচু কর উঁচু কর। হ্যাঁ ঠিক আছে, চল চল আয় আয় আয়। পজিটিভ রিঅ্যাকশন আছে। আরেকটা কেবার দে, আরেকটা কেবার দে। হ্যাঁ মাথাটা কাটবি, নাহলে একটা কি একটা, নাহলে একটা কোন না, একটা কাজ কর না, একটা টিউব নিয়ে, এবার একটা টিউব নিয়ে যদি কাটতে না পারি সেটা লাগ ঢুকিয়ে দে। দেখি সামনেটা রিট্রাক্ট কর, শুধু সামনেটা, শুধু সামনেটা। হ্যাঁ বাস ভালো, সেটা দেখা। হ্যাঁ চল, বেশি ঢুকে গেল। চল খোল, চাবি খোল, অ্যাঙ্গেল গাইড দে। মাথাগুলো কাট, নাহলে কিন্তু খোঁচা খাবো প্লিজ। নাহলে আমি মুখ খুলে মাস্ক খুলে দাঁত দিয়ে কাটবো। কাটবে কাটবে। ও বাবা, টার্জি করের মতোই প্রায়। দাঁড়া, একটা আটারি ফার্সেপ নে, ধর। আরে বাবা, কাটলো তো, তাই না? হ্যাঁ ভালো আছে। চলো দাও, অ্যাঙ্গেল গাইড কোথায়? কত? 135। হ্যাঁ আচ্ছা, দেখি পেরিয়াস্টেমিটারটা দেখি। আমি না বহুদিন ডিএইচএস করিনি, অপারেশনটা পরপর দেখ, ভুল হলে বলিস একটু। হ্যাঁ কিবারগুলো একটু ফাউল করবে মনে হয়। আচ্ছা হ্যাঁ, নেই এটা ফিক্স গাইড নেই রে, এটা অনেকটা জায়গা নিচ্ছে। হ্যাঁ দাঁড়া না, লাগবে দিদি, ঢোকা না ঢোকা না, করে নেবো আমি, করে নেবো। চল হ্যাঁ হ্যাঁ দেখি, দাঁড়া দেখি, ছবি দেখাও। একটু নামবে তাই তো? হ্যাঁ দেখাও, বেশি নেমে গেল নাকি? দেখাও দেখি, দে দে আমার, দেখ দেখ, ঢোকা ঢোকা তুই ঢোকা, চলা না গাইড। হ্যাঁ ঢোকা 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 ঢোকা, যা 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 যা। ওয়েট ওয়েট, ছবি দেখা, নিচে আছে, বের কর বের কর। হ্যাঁ দুটো উপরটা টিপতে হয়, তোমার নিজের মাল তুমি নিজে জানো না বাবু। এই কেবারটা ফাউল করছে। আচ্ছা ঠিক আছে, নে চা, রিভার্স করতে হলে দুটো টিপতে হয়, তলারটা টিপ। দেখা, হ্যাঁ চা, ঢোকা ঢোকা ঢোক, দেখো। হ্যাঁ ল্যাটারাল কর, দেখি সর, বেরিয়ে তুই দুটোই বের করে দে। দাঁড়া দাঁড়া দাঁড়া, সিস্টারের গায়ে লেগে যাবে তোল। হ্যাঁ ব্যাস দেখা। উঁচু 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 ঠিকই যাচ্ছে, মনে হচ্ছে একটু পোস্টারে আছে না অ্যান্টিরিয়ার আছে নাকি? হ্যাঁ আচ্ছা, তুই উইথড্র কর একটু, দুটো টিপে, দুটোই টেপ, দাঁড়া একটু বের করতে কর, যা। এটা পোস্টে হয়েছে? ও সরি, আমি ভুল দেখছি, না না না, হ্যাঁ যা যা, ছবি দেখা, যা হাঁটি যা, ওয়েট দেখা, চল এপিতে আয়। চার হোলের ডিএইচএস আছে তো? চার হোল 135 ওটা কাদের ডিএইচএস এগুলো? ম্যাট্রিক্সের। আচ্ছা, ম্যাট্রিক্সে মেরিল খাবে তো? চ ঢোকা ঢোকা ঢোকা, দাঁড়া দাঁড়া দাঁড়া, দেখাও আরেকটু, যা স্টপ, দেখা 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 দেখা, ব্যাস চল, না খুলে ফেলে। আমাকে একটু প্লেট দুটো দে তো, আমি দেখি একটু। 4 হোল প্লেটটা দে, 4 হোল, হ্যাঁ 4 হোল 135 ডিগ্রি, লং ব্যারেল, শর্ট ব্যারেল না, লং ব্যারেল। হ্যাঁ না, এটা তো এটা মেজারমেন্ট কত আসলে দেখলাম না তো। হ্যাঁ আচ্ছা ঠিক আছে, দেখি এটা কি 4 হোল লং ব্যারেল তো? শর্ট ব্যারেলটা আছে তো এটার? ও না না, এটা শর্ট ব্যারেল লাগবে তো, 70 রে। হ্যাঁ 70, এতখানি গেল তো? হ্যাঁ হ্যাঁ 70 আসছে কেন? 70ই তো, তাই না? তো হবে না, 70 হবে না, 70 এতখানি লেন্থ আছে। সত্তর হবে না, না স্ক্রু ম্যাচিং। এটা কি তোমার সেম লেন্থ গাইড? হ্যাঁ তাই তো আসবে, তাই মনে হচ্ছে। ঠিক আছে, রিম করার সময় বুঝতে পারবো একবার। আচ্ছা এবার আমার প্লেটটা দে, 4 হোল প্লেটটা দে, তা কিন্তু শর্ট ব্যারেল লাগবে তাহলে। 4 হোল হবে না কিন্তু, টিএসপিটা তো 4 হোল না। এইটা কি দিলি আমাকে? 5 হোল করেই দিতে পারি, সেটা অসুবিধা নেই।
হ্যালো ওটি, হ্যালো
হ্যালো,
হ্যাঁ কথা বলুন স্যার।
হ্যালো,
কে অর্ণব?
হ্যাঁ স্যার,
তুমি আমায় যা দিয়েছো বাবু,
একদম ফার্স্ট অ্যাপোলজিজ ফর, বাট আই থিঙ্ক আপনাদের যা টিম আছে দ্য বেস্ট পারসন টু ডু।
দাঁড়াও গিয়ে এটা উত্তর দেবো আমি তোমায়।
ঠিক আছে স্যার, আলাদা করে।
আচ্ছা মানে it was a 3.5 months old intertrochanteric fracture. We can, তুমি পুরনো ছবিগুলো যাও, we can show you the initial x-rays.
Okay.
So then we will have an idea what we are dealing with. একদম প্রথম ছবিটা চলে যাও। ঠিক আছে চল রেডি কর, শুনি তুই শুরু কর না, আমি তাহলে এ করি। তুই আমি তো বলতে চাই তুই এ করতে শুরু কর, তাহলে দিয়ে ওকে দিয়ে দে, টিমার দিয়ে দিয়েছে। হ্যাঁ চলো, হ্যাঁ প্রথম এক্সরে দেখাও। এটা এই দুটো আলাদা করে রাখ। না এটা নয়, আরো প্রথমটা, একদম একদম প্রথম চলে যাও। এইখান থেকে দেখো, এইখান থেকে দেখো, এর তলারটা দেখো, এটা এর তলারটা দেখো। হ্যাঁ মানে এটা হচ্ছে পরের ছবিটা বেটার। হ্যাঁ নো, can camera show on the they're showing it, no? Okay.
Yes sir, we can see. Yeah.
That was after full traction in the fracture table. That's the AP view.
Okay.
And show the lateral view. Next picture, lateral view. That was the lateral view.
Okay.
And which was not moving at all. So we opened it up from lateral side and we exposed anteriorly, and we have cleared the fracture surfaces, and now we have been able to reduce the fracture. Now show the latest X-ray. তুমি তো মেজারমেন্টটা নিয়ে নিস কতটা কি হচ্ছে। হ্যাঁ, এই ছবি দেখা একটু এবারে। I will show you in between. Now Sunit is performing the DHS now. So কতটা গেছে এটা? 70?
3 months old intertroch fracture. Malunited or uniting.
নাহলে তো এটা কাটেনি তো, ল্যাটারাল ওয়ালটা কাটেনি তো। আস্তে যা একটু, না দরকার নেই। হ্যাঁ ঠিক আছে, আর যাস না, একটু ছোট করে দাও ওটাকে। এবার তুমি দেখো ছাড়ানোর পর এর আগে কটা ছবি এর করো। এখন রিসেন্ট ছবি। হ্যাঁ রিসেন্ট ছবি, না এর আগের কটা দেখো, ওয়্যার দেওয়ার আগে, এই আরো একটু আগে, বাস এখানে দেখো, এরও আগে, তলায় যাও, আরো তলায় যাও।
Right. And even if you open and reduce it properly, still nail or DHS.
হ্যাঁ দেখো, now we have been able to bring the fracture down after a lot of struggle. We have removed the fibrous tissue from in between the fragments, and that's our AP view. After we have provisionally fixed with 2K wire. Show the lateral view, next picture. So the next picture, lateral view. There was one lateral view. Here, that's the lateral view. So that was our lateral view. We can see the positive reduction lateral view.
Yes sir, perfect reduction.
So that is the one you can see. Our guide wire is going on through the to the 135-degree angle guide.
Okay.
Now we are doing like here. 60 dish na. 60 screw আছে. We have 65 screw. বেরিয়ে আসবে না 65? And this lady is so small that we are having a size of 60.
Okay.
60. So we are giving a 60 screw. What your plan is to put a DHS and a trochanteric stabilization plate.
Okay.
So Shunit is now going on with the lag screw. That's the lag screw going inside. আর একটা টান, বাস ঠিক আছে, না আর যাবে না। হ্যাঁ, দ্যাটস ফাইন। তাও বেরিয়ে আছে আপনারা নাকি? ঠিক আছে, দেখা যায়, অসুবিধা নেই, একটু বেরিয়ে আসবে। Now we'll pass the 4-hole 135. No, we don't have a 4-hole, so we are using a 5-hole 130. এটা বাড়াতে হবে নাকি? হ্যাঁ, 5-hole 135-degree short barrel plate, because the screw is only 60 mm.
Okay. Only 60. Which screws only 60. Any bone grafting planning, sir?
Probably not. You have got good cancellous surfaces exposed on both sides.
Okay.
We have cleared the fibrous tissue from both proximal and the distal fragment. The retractor,
and also you can see there is a reduction is very good. So contact
reduction
is perfect.
looks stable after looks good after a lot of struggle. দিয়ে দাও nylon hammer. আস্তে ফাটিয়ে দিস না আর্কিল কর্টেক্স। দেখি ছবি দেখো। So that's a plate gone in. Second hole করবি, হ্যাঁ। So because we are planning to do a TSP, add a TSP, so we'll just put a screw through the second hole, because that allows the TSP plate to be put in on the DHS plate.
Okay.
ছোট drill bit, 3.2 ছোট drill bit. এত বড় কেন? We have asked for some blood as well, because we have released a lot of tissue. মাঝখানে লাগছে, হ্যাঁ, না একটু তুলতে, হ্যাঁ এবার ঠিক আছে, না হ্যাঁ গো। ডেপথ গেজ দাও। 34 বা 36 দিয়ে দাও। এবারে গাইড ওয়ার কেবারগুলো বের করে দিই। হ্যাঁ পুরো টাইট করে, পুরো টাইট করে, পুরো টাইট। একটু পরে করলেও হবে। এবার এগুলো রিমুভ করতে পারে, আমরা ছবি দেখবো। হ্যাঁ এবার গাইড ওয়ার বের করে দিলাম হাতে। You can do the compression now, then put the trochanteric plate on top of that. দেখ বেরিয়ে এসো তুমি একটু। হ্যাঁ এবার ছবি দেখাও, একটু উপরটা উপরে ঢুকে দেখাও, হিপটা দেখাও ভালো করে। So that is after putting the second hole. Screw is slightly bigger, but will not change this. Now you are going to put the TSP plate on it. I will compress the fracture, then we will put the TSP plate on it. Traction lose করবে একটু, একটু লুজ করতে, 2-3 টান ট্রাকশনটা লুজ করতে। এখন ছবি দেখবো না, তুমি করো না, লুজ করো না, ট্রাকশনটা লুজ করো। ঘুরি পেছন দিয়ে ঘুরিয়ে করা যাবে না, ওখান থেকে কেন করছো? ও নিশ্চয়ই করছো, আচ্ছা ঠিক আছে, ব্যাস নাও হয়ে গেছে। হ্যাঁ দেখি ছবি দেখি একটা। দ্যাট ইজ আফটার গিভিং দ্য ট্রাকশন। নাও উইল পুট দ্য TSP প্লেট অন। দাও TSP প্লেটটা দাও। ইভেন দ্য 60 স্ক্রু অ্যাপিয়ার্স লিটল বিট বিগার অন হার। এই ওপরটা রুচি দেখাতে হবে রে, নাহলে হবে না, বসবে না। এই এর চেয়ে ছোট TSP প্লেট আছে রে বাবু, এটাই সবচেয়ে ছোট। ওকে ফাইন, দেখি বেরিয়ে আয় তো, বেরিয়ে আয়, বেরিয়ে আয়, দুটোই বেরিয়ে আয়, দুটোই বেরিয়ে। হ্যাঁ এই ছবিটা দেখাতো। Yeah, this TSP plate is pretty long TSP plate. লাগিয়ে দিলে হবে না তো, এইটার সঙ্গে এটা ম্যাচ করে না। এইটার সাথে ম্যাচ করে দিলে, এটার সাথে ম্যাচ করলে তো এটা করা যায় না, তা না করা যায় না, ম্যাচ করলে হবে না। দেখি দেখাও তো। We are trying to do a little bit of modification on the TSP plate. করে দেওয়া যাবে, যাবে না তা না, ঠিক আছে রেখে দে, চল। Now you go ahead, চলো। কিন্তু বাকিগুলো স্ক্রুগুলো হোলগুলো ম্যাচ করতে হবে। করছে because the TSP plate is pretty big for her. That's why we have brought the TSP plate a little bit more down so that we can bring it in the right place. দেখি একবার ছবি দেখাও, একটু নিচের দিকে এসো তো। Though I must admit that this is not the ideal position of the TSP plate. তলায় চলে গেছে বেশি, তাই না? তলায় যায়, অসুবিধা নেই কিছু, অবশ্য এরকম জায়গায় দেখি ম্যাচ চলে আসবে। দেখি ছবি দেখাতে পারটা, আর একটু উঠবে, একটু ক্লিকার আর্টারি ফার্স্টে দেখাতে। We are doing some jugaad system for this lady now too. This is much better. হ্যাঁ একটু হিপটা দেখাও তো, তোমার হাত আসছে, হাত ছাড়ো। This is much better, though not very ideal position for TSP. এবার দেখি হোলগুলো দেখাও আমাকে, হোলগুলো ম্যাচ করছে না, হচ্ছে না, তাই তো? একটু তুলতে হবে, এবার ম্যাচ করবে। করবে কি ওটা না, এটা কি ম্যাচ করছে? বাকিগুলো সব ওটা ম্যাচ করছে। দাঁড়া দাঁড়া, আগে দেখে সব কটা তলাগুলো দেখে নে তো, এদিকে আর তলাগুলো দেখতে, আমি ধরেছি একটা। হ্যাঁ সব কটাই ম্যাচ করছে, ঠিক আছে চল নে, যে কোনোটা দিয়ে দে, তাহলে বাকিটা আমি আঙুল ধরে ধরছি। হ্যাঁ হ্যাঁ ঠিক শুদ্ধ নিয়ে অবশ্যই। এটা আগেরটা কত সাইজ ছিল? 34 তো, 34 দে, 34 দে। হ্যাঁ হ্যাঁ এটা অবধি যাবে তো। হ্যাঁ আমি ডিএইচএস করলে টিএসপি করি, বছরে 2-3 করি, তার বেশি না। একটা রিসেন্টলি তিন কি হলো বুঝে গেল কে ধরা থাক আমি পরেরটা পরে করবো দেখি দেখি ছবি দেখা একটু না লুজ হয়েছে কারণ রেড লুজেরই ছোটো হয়েছে আর কিছু না তলাগুলো দিয়ে দেখা তারপর ভাবছি হ্যাঁ তলায় দুটো দিয়ে দে তাহলে তলায় দুটো 36 দিবি হ্যাঁ ওটা পরে চেঞ্জ এই একটু সিয়ামটা উঁচু কর না আর এখন ছবি নিস না আমি দুই ফাইনাল করি তাও ছবি দিবি একদম তলারটা পাবো ম্যাচ করবে না নাকি করছে ও বাহ ফাটাফাটি না দেখে একটু এটা রিট্রাক্ট করে এখানটা না একটা লিভার দাও রিট্রাক্টটা দাও আমাকে হ্যাঁ $36 দিয়ে দাও এর উপরেরটা দেওয়া যাবে না ফার্স্ট স্ক্রুটা দেওয়া যাবে না হ্যাঁ এটাই প্রবলেম হবে রাইট হয়েছে তো বাস বাস তাহলে এটা দিয়ে দে তাহলে হয়ে যাবে আমার কাজ হলো না টাইট টাইট ভাব হলো আর কি ও প্লেটটা ধরবে হ্যাঁ না এটা 36 যাবে না এটা ভেজে এটা 34 বা 32 দে 34ই দে একটু বড় থাক করে দে হ্যাঁ তো ফাইনাল ছবি দেখি তারপরে আমি পরেরটা বলছি ভালো হচ্ছে না হ্যাঁ বের করলো কিন্তু দেখি এবার ছাড় তো দেখি ছবি দেখাও তো বাবু একটু হাইটটা নামাও সিয়ামে হাইট নামাও একটু হিপটা নিয়ে দেখাও একটু হাইটটা নামাও আর হাইটটা ডাউন করো হাইট ডাউন করো that is more or less our final construct at now chobi now that is a AP view show us the lateral view we were slightly constant in the implant because we did not have the plan for a DHS TSP we just had only one TSP plate so we had to do a bit of jugaad and manage it
Yes sir, we are listening. But actually everyone is appreciating the reduction, especially in such a bad case.
That's the lateral view.
Yes sir, it's very nicely reduced.
And good contact, and good contact. Yeah.
Soumitra Shiva Shankar here. Excellent, excellent. I am also enjoying the way you have been treating this.
Thank you sir.
Yes.
Thank you.
Very nicely done.
Thank you. Oh,
Soumitra, how you are managing a bloodless surgery in 3 months old fracture? I think I could have assisted this case to you.
It's not bloodless.
Sunita didn't allow me to stop.
It's not bloodless, boss. It's not bloodless.
No, I almost we can't see any bleeding outside this skin. See, almost. So as soon as I heard it's a 3 months old, I asked my fellow to arrange for 1 unit blood. But I don't think I will need a blood. It will need a blood transfusion. It's almost there is no blood loss. Yeah.
Now again a bit of jugaad because we have done a bit of change in the TSP position, so we trying to put the first hole of the DHS. 34 de takta. Mepe de.
So TSP plate, this is also from Yogeshwar only, same here.
No, it's a different company.
Yeah,
TSP.
all right. Yeah.
They have only one plate here, so we managed to salvage this case.
Yes. So you are not planning for any bone grafting in the posteromedial void?
Not much void. A lot of some calluses were there.
All right, already there is there.
And they have got good surfaces which are compressed.
Partho wants to ask some question. Partho.
Sir, the TSP plate, is there any hardware hazard for the patient after?
No, not really. Not really.
But it is a prominent part, so is there any
very thin patients, yes, there may be patient may feel it, but I do at least 3-4 TSP plate every year. And no patient complained of anything about the TSP rate. No patient come with bursitis or any other problem.
Oh. Thank you, sir.
Okay, so I think that's done. We are going to close it now. So we can stop transmission.
Yeah. So
Okay.
we are going for, we have started lunch. Lots of people are there inside the hall with plates also.
Okay.
And congratulations. Thank you, Sunitda and Saumitroda, for
Thank
this wonderful
you.
case demonstration.
Thank you. Thank you.
Yeah.
Okay.
And a big clap from hall. Yeah. So please come down. I think Animesh is there. Animesh?
Chandan and the sister to help me. Help
Yeah,
me a
yeah.
little bit of closer, then they can close the rest of it.
Yeah, yeah. So I think Sunitda and Saumitroda, you can come down for lunch. Yeah.
ছবি নেবে দাও
Yeah.
ছবি নাও চারজন একসাথে না আরে এ নাও এক নম্বর নেবে ভাইকিল একটা এক নম্বর নিয়ে নাও এক নম্বর নাম্বার 1 ভাইকিল নাও
Anesthetist কোথায়? Anesthetist
সুভাঞ্জন এদিকে এসো
Main person. Thank you, Subhanjan. Thank you, Sister Sonali and her team. They have been working hard till yesterday 1 p.m. to make
আমার মুখে
everything
বেশি আলো
possible.
পড়ছে ছবি ভালো আসছে না আলো সরাও
सौमित्रदा के चेहरे पे ये आ रहा है, लाइट आ रहा है.
ও এটা না
Yeah. So well done. And so well done and
Thank you,
big clap
thank
from
you.
all. And
Thank
some
you,
words
thank
from
you,
Jaydeep
thank
da,
you.
please.
Thank you. Done, photo session done, okay. চলো এবার আলো দিয়ে দাও করে দেবে
হ্যালো বাঁকাটা হলে নিজে পেয়ে যাবে
thank you all. We are at last come to the end of this academic feast. So, yeah. It is a great achievement that we are really trying hard. We are really trying hard in our, I think Arnav is very much familiar with this kind of situation because we have an e-clinical meeting. We have 1 hour allowed time, but this meeting has done for 3 hours. Exactly. So it is a nice program, and we think, sir, we are very much proud to welcome you on behalf of West Bengal Orthopedic Association, our president, sir, B. Shiva Shankar, sir, and I will request him that we will arrange similar kind of program in our each and every district. We are trying to reach all the peripheral our members who are very much fond of you, sir. So it is our great honor if you kindly consent for that program. We will communicate with you later on. And I will must thank INDCHEMIE, and also I will thank Yogesh sir for their support in all kind of from the yesterday evening to the end of the program. They are actually doing hard. For them we have seen this program. It is actually a program of the All India is watching, and in our YouTube channel, thanks to Arnav, and it is a great effort by Rajiv. I think Rajiv is the main key person for this program, and also Somodev is the backbone. Don't think that I will not Biplav is silent. Biplav Kumar is our EC member, but he is doing silently. Utpal he is also doing the thing in his own way. In the mid of the thing, in the mid of the meeting, these two our past secretary Kiran Kumar Mukhopadhyay and Utpal Bandyopadhyay has attended a program. In sir, please the program is by the NGO, and it was a social service. So we are very much fortunate that we have these members with us, and I also thanks a lot for giving us the opportunity to do this program. Our hospital, the name is same, JBCH, and also Jadip Choudhury sir, for this excellent institution. Really, it is a dream that we are working in this institution. We are thinking, but sir is doing every kind of thing, and the OT is the world-class OT, I think. Everything. If I ask a osteotome, they are supplying 10 osteotomes in a set. If I ask a nibbler, they are supplying the set of nibblers. So this is I think the joy of this institution is this. That we are thinking of that, we are dreaming of that, and our dreams come true with the hand of Jyoti sir. So it is a great applause for sir. And I will not. Yes. They are doing really a wonderful job, and I will request our office executives, Kakoli Sinha and Prosenjit. I think Prosenjit, where is Prosenjit? Prosenjit is. It is their effort, so that we are doing this program with the help of them only. We are doing this program, academic program, so that the daily activities are really they are managed very well. So it is, we always try to motivate them, and I think Dr. B. Shiva Shankar is doing the right job, that we are motivating them to function, to do their duties. May I ask Shiva Shankar sir to please say a few words?
Mentioned a lot of good things about this place. The only my feeling is that hardware you can buy with money. That's if you have money, you can provide 10 osteotomes, 10 drills, writers, saws, nothing else. But it's mainly the soft skill which matters. It's the human support which matters. I'm very proud that I've got an excellent team of my colleagues and juniors who have been, from day one, they have been very supportive, and they have made this successful project. There's one thing for address to our president. We also take care about on the educational side as well, and training from this institute. We have got 2 fellows, one in arthroscopy and one in joint replacement. They do a 6-month resident fellowship with us, and this is the 6th session we are running with 2 people. We we have got observership programs, the people from Bangladesh, Nepal, a lot of people come over, but we may need help from you just to expand on this educational side. From time to time, we would bore you. Thank you.
Oh, sir, one more thing, sir. There is a proposal from me to our editor, Dr. Sanjay Keskar, who is not here today because some commitment. But we have actually his proposal that we can make this intertrochanteric discussion a symposium, and we can publicize a supplemental issue after the EC's permission. We will discuss it in the EC next month, this month, and then we can publish this issue. And really it is a matter of thing that we have got this institution, and we should work on this institution so that this institute can be well known to all India and other international levels. मैं जी नहीं मुझे
without Patwa has already thanked everybody, but I think a special vote of thanks needs to go out to our industry, because without their help and support, I don't think we could have arranged anything like this. So I would like to invite one each from Yogeshwar Implants and INDCHEMIE to come and tell us a few words.
Thank you one and all over here for giving us this opportunity to explore ourselves over here and make awareness about the new techniques what is coming up in orthopedics. And I hope that every one of us has taken a maximum advantage of it. And we would like to see once again all of you over here with the newer techniques and newer instruments. Thank you once again to the management of JBCH and Dr. Rajiv Raman sir as well for giving us this opportunity. Thank you once again.
This is Nana Rao from INDCHEMIE, and I would say that I'm basically from BONESTAT division. So I thank everyone for giving us a very good exposure for this particular brand, and I especially thank Rajiv sir and Shiva Shankar sir for giving us this opportunity. And we would like to do this kind of educative program in future, and please strengthen our hands. Thank you very much.